one, go.
Saiti, shall I start?
Yes, ma'am. We are live now.
Okay. So, good evening, everyone. Very warm welcome to the societies of Jaipur, Alwar, Ajmer, Udaipur, Bikaner, Hanumangarh, and Ganganagar. A very warm welcome to our series of E-Classic for Clinicians, PPH Skill and Drill. We all have, as obstetricians, we must have all faced the wrath of PPH now and then, and we must have also sacrificed the uterus. So whenever there is PPH, unless you follow a well-defined protocol, everything runs helter-skelter, and then you are in a mess. So this is the very aim of our webinar today. When a patient lands in PPH, how to do things in a well-organized manner. We have so many options. Earlier, we had oxytocin. We have better uterotonic now, carbetocin, which we are giving for prevention of PPH. Apart from this, before we land up in an obstetric hysterectomy, we have so many options, be it the bimanual compression, aortic compression. If the patient lands in shock, we can put NASG garment. We can go for uterine balloon tamponade. If needed, we also have SR cannula, which sir will be demonstrating today. If needed, we go for stepwise devascularization, the B-lin suture, so many other compression sutures, internal iliac ligation. So through this webinar, our aim is to pass all these protocols to each and every society from north to south and east to west. And the person behind this hard work is Dr. Sadhana Gupta ma'am, who has been working tirelessly since so many months. We have covered so many states, so many societies, and each of the societies, we're very pleased to listen to these webinars. They are really useful. So I would like to, first of all, before starting the webinar, let us all join hands and let us all think of Ma Saraswati, the goddess of knowledge, and join for the lighting of lamp. So let me now take the privilege to invite the person behind all this hard work, Dr. Sadhana Gupta madam. Madam is co-chair Suffolk NCT committee. She's FOXY representative to Suffolk and vice president FOXY 2016. Madam has been ICOG governing council member 2015 to 21 with best governing council award in 2021. Corresponding national editor and peer reviewer, Journal of Obs and Gynae and Journal Suffolk. Madam is thrice country representative to WHO on key women health issues. She is thrice Korean Award winner for the best scientific research paper.
Dr. Sadhana, let it be.
And she's editor 7 Safe Motherhood Bulletin. Ma'am has conducted so many conferences, CMEs, workshops, and above all, Madam is the most deserving FOXY presidential candidate 2023. A very warm welcome to you, Sadhana ma'am. Kindly invite and introduce our chief guest, Dr. Veena Acharya, President of Rajasthan branch of NARCHI. Am I audible?
In between a little bit interruption, otherwise you are audible.
Okay.
So first of all, a warm welcome and thanks to Udaipur, Ajmer, Bikaner, Hanumangarh and Ganganagar societies to join together on yet another very, very important topic, pertinent topic, that is postpartum hemorrhage and E-Classic for Clinician Skill and Drill series. So my hearty thanks to Dr. Prakash Jain, Dr. Pradeep Panwal from Udaipur, Dr. Purnima Pachori, Dr. Sandhya Kumari from Ajmer, Dr. Sudesh Agrawal, Dr. Rajeshri Chalia from Bikaner, Dr. Renu Setia, Dr. Prerna Rathod from Hanuman Nagar, Dr. Sunita Agrawal and Dr. Neelam from Alwar, Dr. Nikita Tehrija and Dr. Sunita Chaudhary from Ganganagar. So because of all your efforts, actually we are together, and it is a great beginning. Actually, when we are together for a certain cause, vision and mission, then actually the things really start taking change. So gratitude for all to joining together, and it is why this conception for the E-Classic for Clinicians series, why it is a name, because in today's world, and what I get feedback from all the teachers, especially the senior teachers like Dr. Veena Acharya and Dr. Leela Vyas, that the people today are not like having that important and strong foundation of the basic and classical teaching, and they get confused with the sometime evidence, sometime conflicting and inconsistent evidence. And our aims to give the classical teaching, which is the supported by strong evidence. There is no confusion and controversy about it, so that everybody who joins these programs has a clear roadmap that what they should do when they face this particular situation. So this is something, a thought process behind this name and behind this series. So it is a great pleasure to be with the mentors, seniors and teachers for all states. And it is a real honor to have Dr. Veena Acharya. It has been around, though I am not a student of Madam, but how this long association for 30 years, when I was so young, and we have been in Jaipur for the AICOG, for the NARCHI conference, and how we get inspired, like the people like Dr. Veena Acharya, for a tremendous work on the prevention and the screening for cancer cervix. So we are really blessed to have teachers like Madam. Dr. Veena Acharya is Senior Consultant Head of Gynae Preventive Oncologist, Rajasthan Hospital, Jaipur, Chairperson of ICMCH, President, Rajasthan Branch of NARCHI, JOGS, ISSPP and the Fertility Society, Patron of Association of Gynae Endoscopic Surgeon of Rajasthan, National Executive Member of Indian Society of Cervical Cancer, and the Director, Colposcopy Center and National Executive, ISCCP. She has been awarded Chikitsa Vibhushan Award on Doctors' Day, Appreciation Award by many, many societies, and she is a sought-after faculty for all the programs which are related especially to the cancer cervix. And Madam has produced the generations of students who adore her, who are motivated by her, and it is a real great honor to have Dr. Veena Acharya with us on the today's program. We are looking forward to listen from the words of wisdom from Dr. Veena Acharya.
Thank you, Dr. Sadhna. A very good evening to all the members of the organizing committee and the distinguished guest and the secretary and president of various society of the Rajasthan. And it is really an honor and privilege for me to be here today as a chief guest, Dr. Sadhna. It is a program of utmost importance, the postpartum hemorrhage skill and drill, which you have chosen. That is a great. And I would like to express my gratitude to the organizer, especially Dr. Sadhna Gupta, for inviting me for this useful webinar. And I congratulate Dr. Sadhna for her dedications toward the raising the awareness and about the postpartum hemorrhage. This is the really very critical issue that affect the health of the well-being of the countless women all over the world. And postpartum hemorrhage is significant cause of maternal mortality and morbidity. We all know about it. But every year we are watching, every year thousands of the women lost their life due to the preventive condition. We all know that. And it is the matter of the great concern, and it is required the urgent attention from the healthcare provider who are at the different level of the health. To effective combat of the postpartum hemorrhage, we must focus on the several issues, and first and foremost about the awareness, educations among the first in the pregnant women, their family members, and explain about the gravity and seriousness about the life-threatening problem that is very crucial. And there is a need of strengthening the healthcare system in our country, particularly in low resource settings, to ensure that the skilled birth attendant should be available during the time of delivery, and they should have the full knowledge about the how to manage the postpartum hemorrhage, because in our country we have different level of the healthcare system in our country, PSC, CSE, district level. So that's why we are facing a lot of problem, and still the cause of the death in our country is the one of the most important is the postpartum hemorrhage. And it is associated the promoting the multidisciplinary actions. So we all join together, all the healthcare workers should be joined, and there should be complete correlations and cooperation between the obstetrician, anesthetists, nursing staffs, so they can have the proper healthcare system. And CME and this type of the webinar play a vital role in the understanding of the postpartum hemorrhage and identify the innovative situations which doctor from the Kerala has mentioned just now. Tracking the postpartum hemorrhage required the collective approach and efforts from the healthcare provider. By joining the hands together, we will definitely substantial impact on reducing the incidence and consequence of the postpartum hemorrhage death, ultimately saving the countless deaths in our country. Thank you so much for inviting me, and all the best, Dr. Sadhna Gupta, for your future and whatever the efforts you are doing. I'm really grateful and thankful to you that you are doing day in, day out your work in every part of the country. Thank you so much for inviting me.
Thank you, madam. Your words of caution, and that how it is not only the person, you rightly emphasize the like maintenance and the working a very, very good functioning health system right from the community to the tertiary care center. So that is the need of time, and rightly you say that we have to bridge many, many gaps in our healthcare system in the continuum of obstetrical care, so that we can have all preventable mortality related to postpartum hemorrhage. Thank you, madam, for your precious time, and now for your most precious blessings for my Foxy presidential candidature.
Yeah.
We are really blessed. Thank you, madam. I'm really blessed to have your precious wishes, and it is a great pleasure. Thank you. Thank you. And it is a great pleasure to have Dr. Leela Vyas, who is one of the very close and what we can say the natural connect friend. And Dr. Leela Vyas is an ardent teacher. She is gynecologist in Jaipur, Rajasthan, and experience of 33 years in the field. Her special interest is high-risk obstetrics, infertility, cosmetic and aesthetic gynecology, and endoscopy. She has graced the position of professor and head of the department at SMS Hospital, Jaipur, and currently gynecologist at CTS Hospital, Jaipur. She has been our vice president of Foxy in 2018. And she is a very strong pillar of the Manyata project in Foxy, and she has been the organizing key resource. Like in our vice presidency, we had a very, very lovely West Zone Yuva Foxy at Udaipur. So it is Dr. Leela Vyas' humility that she has really cut her CV short, and she's a known figure who really works at the ground root level for the change. So thank you, Leela ji, for being with us, and we look forward for your words for this program and for all the things around us. Dr. Leela.
Namaskar, Dadar. And at the outset, thank you very much for calling me in this. And really, to share the stage with Dr. Veena Acharya, Veena Didi, we used to call her. So Veena Didi is chief guest, and if I am a guest of honor, it's a very proud privilege for me to that. The topic, as rightly said, Dr. Veena Acharya said that The topic you have chosen is PPH. I think you remember we were in Kanpur last conference and we were saying that everyone should pledge that there should not be a single death due to PPH. PPH will occur. Sometimes it is mismanaged, sometimes it is unknown, sometimes there are all predisposing factors are there. So predisposing factors are there, high risk cases, so PPH can occur. But if we'll place that we will save our mothers dying due to PPH is our best means giving towards our society that those years we have worked and we all learn from our patient group. So thus to return them is our responsibility. Yes, systematic approach is very important. We have seen that in different institutes, some hodgepodge jata. But end of the result, if patient saved, we say, oh, chalo, jo bhi kiya, if senior is coming, they say, oh, you have saved the mother. So the main output is that to save the mother. But if we go with the right approach, definitely there will be a less damage to the patient. We don't want to increase morbidity. You just want that decreased mortality, but simultaneously the morbidity should be decreased. So you have planned that you are going to, Dr. Sadhna ji is going to speak on everything, कैसे resuscitate, कहाँ पहचाना, कहाँ ठीक किया और कहाँ यदि बिगड़ गया तो उसको भी ठीक किया. That is it. And then you have called the Dr. Samatram that he has invented that to do the suction in these patients. What is the role? So everyone from the Rajasthan going to learn from you. And then Dr. Shashi, she is going to teach us that step-wise event. So Sadhna ji, आपने सब masters को इकट्ठा किया है, and that is very good. And to involving all our Rajasthan society again, thank you for that, because we Rajasthan looking towards you that we will get some new points every time in your webinars and we'll get benefited. And really, as you rightly said, that there is some connect friendship we have. We don't know how we got connected. For the last 10 years, we are very actively participating all together in every field. So this all the best for your future, this endeavor. And we expect that you should get all victory in your life. So thank you very much, and all the best for this everything. And all my Rajasthan friends, really, you all are participating, all are very learned. And Dolly is also there. Dolly is my student. She is from Ratlam. Again, and Dr. Shukla and Dr. Ayushi, they all are working hard and they were calling, "Kya hua, madam, kuch bhejo sahi hai, hum thoda sa delay kar dete hain." Sorry for that. And again, thank you and congratulations.
Thank you, Leela ji. We really look forward for working together for a change in our country and in all reasons. Thank you, Leela ji. So, Babita, you can go ahead with the scientific session. And I will request that please rename yourself who have joined with the name of doctor so that we can have a very smooth communication. You can go ahead.
So thank you everyone for your pearls of wisdom. Now let's quickly move forward with the scientific session number 1. Our speaker is none other than Dr. Sadhna Gupta, past Vice President Foxy and co-chair Suffolk Density Committee. She'll be talking on resuscitation and medical management of PPH. I would like to invite our esteemed chairpersons for this session. Dr. Sunita Agarwal ma'am is a renowned obstetrician and gynecologist, and she is president of Alwar Obs and Gynae Society. A very warm welcome to you, ma'am. Then we have Dr. Prakash Jain. Sir is president of Udaipur Obs and Gynae Society and is affiliated with Foxy. A very warm welcome to you, sir. We have Dr. Devyani Ranawat with us. Madam is past president, Alwar Obs and Gynae Society. She has special awards and achievements. The past president Obs awarded all the 5 prizes of category C in AICOG 2018 Bhubaneswar. She is Manyata Assessor and Dhira Master Trainer. She has publication in newsletter AOGS, paper presentation in AICOG 2009. A very warm welcome to you, ma'am. Now I hand over the virtual dais to our chairpersons to conduct session 1. I would request Dr. Devyani to introduce Sadhana ma'am and then continue with the webinar. Dr. Devyani?
Yes, a very
Okay.
good evening to all. Dr. Veena Acharya and Dr. Leela Vyas, I welcome all. Dr. Sadhana Gupta needs no introduction because already her introduction has been given in details. So I invite her to present her very needed topic, resuscitation and medical treatment of PPH, which is the most needed and which is the most dreaded complication in nowadays in obstetrics and needs urgent and most systematic treatment. So I invite Dr. Sadhana Gupta to deliver her talk.
Thank you, Dr. Devyani, and once again, my warm regards to all dignitaries and faculties and office bearers of all the society. Dr. Sunita, my regards to my chairperson, Dr. Sunita Agrawal, Dr. Prakash Jain, and Dr. Devyani for your kind introduction.
Good evening, ma'am. Good evening.
Good evening. Good evening. Hello. So nice to have you. I'm going to deal with something very simple what Dr. Veena Acharya and Dr. Leela Vyas says, that so many times, so many things people do in like a uncoordinated manner, and if the patient survives, it's okay. It's all we forget, and if it is not, the result is not that good, then we have a lot of issues and a lot of scolding, and then again we go on to the work. So the purpose of like this 20 to 25 minutes talk is to emphasize that actually when we are, what we can do in our routine OPD, what we can do in our labor room practices to prevent postpartum hemorrhage, and when we encounter a case of postpartum hemorrhage, our roadmap should be clear. So first of all, thank you for being together. What I was just saying that मेरा ननिहाल राजस्थान में है और मेरा जो भी संस्कार है, स्वाभिमान, स्वतंत्रता, वैल्यूज के लिए संघर्ष करने और त्याग करने की क्षमता, उसमें बहुत कुछ मैंने राजस्थान के जमीन से लिया है. It has been a great journey, and we had a wonderful time. Just recently concluded West Junior Foxy at Ranthambore amongst nature and amongst the strong people for the Rajasthan. So I owe a big gratitude for always being together. And I bring greetings from my Karma Bhumi, that is the place of Lord Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. And that peace, that the inner peace and strength is so very important when we are dealing with the postpartum hemorrhage. So we all know the statistics that PPH is contributing around 35 to 40% of all maternal death. Maybe in developing world, it is contributing to 60% of death. And what is the conscious picking statistics that Africa and Asia is constituting major proportion of maternal death. But what is the clinical perspective? That it is bound to occur in 2 to 10% of all deliveries, and out of which 1 by 1,000 can be massive. And we have to have a very aggressive approach, and sometimes the terminal treatment, that is obstetrical hysterectomy, may admission to ICU, massive blood transfusion, they are all category of the severe acute maternal morbidity or near this. And it is a lifetime scar for obstetrician and their team. The memory of Dr. Archana from Dosa is still alive, when she had very, very unfaithfully, she committed suicide after a death from the postpartum hemorrhage. And that tells what amount of medical, legal, media and the social pressure can be on the treating obstetrician. So it is our India that we are like PPH is contributing to 35 to 56% of maternal death. And as a presidential candidate, what we are inspired by the teachers like Dr. Veena Acharya that we have to have the zero mortality from the preventable mortality from the postpartum hemorrhage. So how we actually get ready? We don't get ready for any emergency or for anything in a day. PPH tests the functioning of our health system and skill of our all team, not only us as a leader, obstetrician and gynecologist, but skill of all health workers, because it is often unpredicted and presents like a thunderbolt, and we are going to have in around 10% of one. And we can lose the patient very rapidly in a short span of 1 to 2 hours. And that's why the PPH management tests your everything, your leadership, your guts, your strength, what amount of effort you are putting into your health system. So it is a real litmus test for all of us. In India, we have all the issues of the age-old problem. We are struck, every third woman is anemic. We are still having pre-delays. We are still lacking a very respectful sound referral system, but we have also the all new challenges of the Western world because we are having the changed obstetrical demography. Or we are encountering pregnancy with myoma, obesity, medical comorbidities, and the patient with a coagulopathy or on anticoagulant for various reasons. So we have to face this situation very, very coordinated way, and good decision making among chaos, confusion and complexity is the thing which we wish to achieve through all these educational, physical or virtual, academic and the skill learning and the skill and drill workshops. So because we know when we lose the patient, it is a lifetime scar for all of us. So what can be the implication of suboptimal management? It is not only threatening well-being of mother, but also neonate and the obstetrician, and what is it? It is a potential medical, legal, media and the social issue. Now, this is the time when our political system, like 15 or 20 years ago, we say that we don't have that political will. That political will is very much around us because we have rural health mission, we have the community health worker, we have very good roads, we have 108 ambulance at the just call. I have seen a water ambulance just in my visit to Jorhat. So the political will is there, and it is our onus that we strengthen our system and our skill in dealing with the postpartum hemorrhage. So can we prevent PPH? It is $1 million question, and the two things are there for our strong foundation for prevention of PPH, that is identification of risk factor in antenatal care and universal adherence to active management of third stage of labor. So all these are the risk factors for the postpartum hemorrhage. All August obstetrician and gynecologists are knowing about it, but important thing is that we have to take the suggestive history, we have to take down the notes of the ultrasound and put in the red color on our antenatal card and in our case record. So if the patient says she had PPH or a blood transfusion, if there is a low-lying placenta, if she is pre-eclamptic, this is the time that we put these high-risk points on our antenatal card and counsel the family for the PPH risk, because the unawareness, unreadiness of the family also going to complicate the picture because they are not ready for it, they are not ready for the blood transfusion. And when you have to sensitize the family that if you go to any place for delivery, show these cards so that all labor room staff is ready for all the preventive measures. Now, AMTSL, active management of the third stage of the labor, is the thing on which I have spent around 10 years of my journey in FOXY. The oxytocin to be kept into the fridge. And when we did the Helping Mother Survive and the Path Oxytocin initiative, as a chairperson, Safe Motherhood Committee, then I came to know that oxytocin was to be kept into the fridge and it was not being stored at the fridge. And the different unit even in a one hospital have the different practice for the active management of third stage of labor. With a great effort, we have come a long way. And now the WHO emphasized on most important arm of active management of third stage of labor, that is oxytocin agent within 1 minute of birth of the baby. Why MTSL for all? Because it reduces third stage, it reduces risk of PPH, reduce severe PPH, decrease need for blood transfusion, decrease risk of anemia, and additional utrotonic. Oxytocin is the drug of choice because there is no at all, not a single contraindication for oxytocin. So every nurse, every person is like authorized and can give safely oxytocin. You can give it intramuscular, you can give it IV if the IV infusion is already there. Misoprostol, a lot of obstetricians are using. I wish to have a word of caution that it is a second choice after oxytocin. It is not a first drug of choice. And the beauty of this drug is that it is a cheap and it does not require that cold chain for the shelf life. Though it can cause a shivering, vomiting, diarrhea, and if you are using it per-rectally, the effect is after 20 to 30 minutes. So if you wish to give it as a active management of third stage of labor, give it orally or sublingually. So all professional body emphasize that every woman who is delivering must have active management of third stage of the labor, and administration of oxytocin agent within 1 minute of birth of the baby is the most important arm of AMTSL. We have waited a long to have the carbitocin, which is a long acting, and we have oxytocin, and we have the room stable, and as well as the carbitocin, which has to be kept in the cold chain as well. I wish to emphasize that even the room stable carbitocin need the storage shelf life at 2 to 30 degrees centigrade. And when now in May or June, when we are having temperature of around 39 to 42 degrees, it is still better that we keep carbitocin in our fridge shelf. It is important because it has a very, very strong affinity for oxytocin receptor. India was a main contributor to the champion trial, which showed that it is effective in our race and in our ethnicity. Most of the studies have been done as a MTSL for cesarean delivery, but we now have a very good high-powered studies that it is a very good method of active management of third stage of labor, even in vaginal delivery. So, few important points for the caution that it is to be used only as a single dose. So, while we reuse oxytocin, methergine, or the PGF2 alpha, it is not to be repeated. It is always to be given after delivery of the infant, and it has to be like when you are using as a management of the PPH, then it has to be used in the other measurement or in the other armamentarium also. So it is a long acting, and the third beauty of the carbitocin is this, that it eliminates the requirement for infusion after initial dose. So what was the problem? What Dr. Leelavya says that like our work with the field purpose. Patient has a twin delivery. So we say, you don't stop, give 10 unit, then 5 unit oxytocin. But nurse stops, like sometimes she forgets. Sometimes due to anemia, like the pre-eclamptic patient, when we don't want the fluid to be overloaded, then the use of carbitocin actually eliminates the requirement for further oxytocin infusion. And that's why in total, it is a very, very cost-effective and the safe drug. And I really appeal to all people who are not using carbitocin that it is one of the strongest armamentarium which has been added to deal with the postpartum hemorrhage. Finally, for all practical purpose, be it oxytocin, misoprostol, all utrotonic drugs, they should be available at the bedside of the woman. We must have the refrigerator close to the labor room. Our nursing staff must be confident enough and must be knowing very well that these drugs should be given after delivery of the baby. And we must have, as a leader, ongoing audit to monitor that our 100% of women actually receive the AMTSL. The other component of the arm of the AMTSL are the late cord clamping and the control cord traction. It is only when there is a skilled birth attendant available who knows how to do the control cord traction. So WHO has given this bar, and this is very important point that any new nurse or any new house surgeon who joins the OB/GYN labor room they should not be allowed to do the control contraction, because if it is not done into the right way, it itself can cause the postpartum hemorrhage. However, PPH can be unpredictable and we have to be ready in peace. It is not that we are ready when the all guns are shouted, we are having a moderate to severe PPH. We have to invest in our day-to-day healthcare system, and we should be ready with our fire drill. So why do we lose whether it is delay in correction of hypovolemia and delay in control of bleeding? And it is the first 1 or 2 hours where we have to be very, very aggressive, because in first 2 hours, if you diagnose PPH well, if you treat it well, and if you make the good cause analysis and stabilize the patient, there are much more chances, much higher chance that we are able to save the patient's criticality as well as the mortality. So we all know what is primary and the secondary PPH within first 24 hours, after 24 hours to 24, the first 12 weeks. But when you are being called to tackle with the case of PPH, what you do? Make quick 360-degree review of whole situation, and aggressive resuscitation and the cause analysis should go hand in hand. These things, the resuscitation is by hands of the multiple people, and the analysis of the cause analysis in the brain of the obstetrician. We all know what are the classic teaching: tone, tissue, trauma, thrombin. Important thing is that in particular patient, what can be the one cause or the multiple cause? That is the smartest thing to accumulate that what has been the situation. So if the woman is having the PPR or chorioamnitis, she has been high parity, she has been induced for a long, or she had the obstructed labor, prolonged labor, more chances to having atonic uterus. Does she have a fibroid uterus? You can have a atonic hemorrhage as well as the traumatic hemorrhage. If there has been the multifetal pregnancy, again it can cause the atonic. If it has been a difficult delivery or delivery of large size baby, think for the trauma. And if the patient is having any precedent obstetrical situation like preeclampsia, like intrauterine fetal death, always think of coagulopathy. So important thing is not in summarizing. Important thing is that how we quickly analyze that what is the cause of postpartum hemorrhage in this particular patient, because only then you can correct the source of the bleeding. You can have more than 2 or 3 causes because it was prompt infection, use of mexalphenifadipine, atonic, they all lead to atonic postpartum hemorrhage, and all can, if the patient was in aspirin, then the coagulopathy also sat in aspirin or heparin. So we have to think of the multiple cause as well. What are the pitfalls in diagnosis? So what is important? First is there is a small bleeding, vitals are okay, and the nurses or the JJ, so it is okay because it is okay. So important thing is because nature has made that the pregnant woman is having hypervolemia. So they can tolerate mild amount of postpartum hemorrhage without any alteration in the vital. So the monitoring of women immediate postpartum cannot be left to inexperienced person. You have to give clear instruction to your nurses and the junior resident that if the patient is having the 5 soap normal size pad, 1 soap big sanitary napkin, she is having continuous trickle of blood, or the patient is not looking good, she is cold, she is nauseating, she is vomiting, then this is the time that urgent call to senior obstetrician should be made. So this is the capacity building of the all level of healthcare provider is the important thing, and they must have the clear instruction and regular drills that when to call the obstetrician on call, and our all team to call for the help who must be available when we are dealing with any sort of postpartum hemorrhage. And who are our friends? It is anesthetist, senior nurse, our obstetrician colleague, ward boys and guys who are the smartest, theater staff. We have to inform theater staff that this patient is having PPH. We might need the operation theater open and the all equipment ready and the blood bank person. So it should not be the call to the walls. It should be the pre-designed whom to call when we have the PPH. what is the cause analysis, and after this, what is the degree of postpartum hemorrhage, because accordingly you manage the patient. So these are the pulse, blood pressure, tissue perfusion indicator, urine output, and capillary refill. It is not a very rocket science. It does not require very, very high infrastructure as structure as well. But we must have the multi-parameter cardiac monitor in our labor room. Now, this is one of the very important key steps, that we must have the multi-parameter cardiac monitor in our labor room like we have in our operation theater. And the second thing, the patient after delivery should not be shifted to the normal like postnatal ward unless the time period of 2 hours have passed and patient is fine. So you can check urine output, you can do the capillary refilling, and you can check the blood pressure and the pulse rate, and which gives you idea of the shock index, which is the simplest of the thing which we can have the assessment of the what amount of blood loss the patient have undergone. So if it is less than 1, you have the breathing space, but if it is more than 1 or 1.5, the patient have the moderate to severe PPH, and our efforts should be very, very aggressive. Rule of 30, we know it is just important again that our nurses and our all level of resident doctors are aware of it, and they are alert to change in the situation of the patient. We need that much 24/7. If even 1 or 2 patients are delivering in our labor room, all oxytocin drug, oxygen cylinder, emergency tray for PPH, chart for PPH management, and contact number of all the people we need in the health. So this is what is the basic resuscitation, that is you have to arrest the bleeding and you have to replace the fluid. Give antibiotic, record event, and communicate. This is the ongoing thing if we really want to save ourselves from all potential medical, legal, and the all pressure and the media issues. So if there is a more than 500 to 1000 ml, you have to be ready with all resuscitation process, which must be very, very aggressive. And one point of caution, because in PPH, the non-technical factors were so importantly. So if your nurses have called some time to the patient and patient was okay, never scold them that why you called me at midnight or why you called me, because next time they might be afraid of calling you. So look for airway, breathing, and circulation. Give oxygen at 10 to 15 liter, whatever is the pulse of this oxygen saturation, and obtain 2 IV access, that is from the green and the gray cannula. So I will say that no pink cannula in our labor room. Keep the patient flat, keep the patient warm. If you have not given carbetocin, you can give. You have to be ready with all oxytocin drug, catheterize the bladder, and at the same time send the blood for the cross matching and this all investigation. Aortic compression, placenta percreta like situation, when the patient can lose the blood, a lot amount of blood in a very short span, we must be ready with our all efforts how to do the aortic and the bimanual compression, how to stand on the stool, give the pressure with the straight elbow, and that pressure that much that you are not able to feel the femoral pulse. So these can be the life-saving temporizing measure, and you have to resuscitate, investigate, monitor, communicate, and the record keeping. When you are putting the second IV line, at the same time you send the blood for cross matching, you send the blood for all liver function, LFT, liver function, kidney function, coagulation profile, hemogram, as well as the prothrombin time. For this, you must have the 3 plain vial, 3 citrated, and 3 EDTA vial in your PPH box. So sometimes we are careful about the drugs, we are careful about the other thing, but the absence of the blood transfusion requisite form or these simple cannulas make a loss of time, and the nurses are going from here to there where it has been. So these are the few important non-technical points. So the PPH care bundle is has been proposed by the FIGO and WHO, which is a selection, implementation of 3 or 4 things which should happen. And this include uterotonic drug, isotonic crystalloid, tridexamycin, and the uterine massage. And if they are not responding to first response, then we go to the refractory PPH bundle. So it is airway, oxygen, and the crystalloid. Police catheterization, warming the patient. So a word about the crystalloid. What is the fluid of choice and what is amount of the crystalloid? So the fluid of choice is ringer lactate or normal saline, which is isotonic, and amount should be around 2.5 to 3 times what you have estimated. So if you are estimated that it is 500 ml, you give around 1.5 liter of crystalloid. Never start with the colloid, which is a common mistake. Sometimes people make it because it is costly, it remains intravascular, and it can cause pulmonary edema. And it also interferes with the coagulation profile. So ringer lactate, normal saline 3 times. Colloid is coming into the picture when you have given around 2 liter of crystalloid and blood component is not available, then you can give the colloid, that is hemexin. When resuscitation in place, ask right question. Placenta is delivered, and if so, it is complete or not. For this, again, a non-technical issue, give very clear instruction, no placenta will be thrown away into the biomedical waste before the golden hours has passed, because you want to recheck that placenta was complete or not. If placenta not delivered, mobilize team for MRP. If placenta not complete, explore genital tract in good setting. But if there is a suspicion of placenta acquita spectrum disorder, never and no attempt to remove the placental part, as this may lead to catastrophic bleeding. Few basic obstetrical technique, that is the fundal massage, which should not be the very harsh. It should be a circular movement, emptying of blood clot from the vagina. These are very, very important things which every woman, every obstetrician and every nurse must have, and they should be trained into that, and we have to follow, see that they are doing these simple procedures in a very coordinated way. What are the oxytocin drugs? These are oxytocin, carbetocin, methyl ergometrin, misoprostol, and prostaglandin F2 alpha. They are all very good oxytocin drugs which cause the contraction of the uterus. Important thing is, first, they should be available in good amount in then and there. Second, they should be optimized with the guide. You can repeat the dose, how much the drug methyl ergometrin we can give. We can give 4 ampules of methyl ergometrin. We can give 8 ampules of prostaglandin, so that optimize the use of oxytocin drug before you think that it is a refractory to oxytocin drug. So availability, good storage, and the optimum use of these oxytocin drug is the thing where we can have the missing chain in management of the postpartum hemorrhage. Always we should have to look what are the contraindication for particular drug, like methyl ergometrin, contraindication, valvular heart disease, anemia, hypertension, prostaglandin if it is an asthmatic patient. So it is important that we have a quick analysis if there is any contraindication. You can use the succession of the drug. If you have used carbetocin as active management of third stage of the labor, for management you need ergometrin, PGF2 alpha, and misoprostol. If you have not used, if you have used only methyl ergometrin, you can safely give misoprostol and PGF2 alpha, because the different oxytocin receptors are received by the different drugs. So every drug have got its own receptor, and if one drug fails, the other drug might work. So this is important. However, if you have given 3 doses of PGF2 alpha, that is prostaglandin, or you have used the 3 doses of methyl ergometrin, this is the time that we should think that we might need the second level measures for dealing with the postpartum hemorrhage. Tranexamic acid has come into armamentarium as a medical management for the postpartum hemorrhage after the oxytocin drug. And it like in my long journey of Foxy and the FIGO and the CEPOG, we were like when the first reports after the women trial were presented in the FIGO session, and now it is recommended by WHO and FIGO that tranexamic acid should be given prophylactically in a woman with high risk of PPH. And on recognition of PPH, you can give first dose and repeat within 1 hour. And if you give after 3 hours, it might not be effective. So these are the WHO and the FIGO recommendation that tranexamic acid is a drug which has to be used within 3 hours of the recognition of the PPH. This is again very important slide and paper which have been just recently published in 2020 from the Western world by the anesthetic. That tranexamic acid, due to its similarity with the bupivacaine, has been used as a giving for the regional anesthesia. And in our old Delhi National Medical Council, we have few cases like this. So a magnifying glass in our operation theater, and also as a professional body, we have to give this strong advice to our manufacturer that they don't have the similar appearance of the ampoules, which can cause, especially in a busy OTs and a busy day that the human can have. So this is very, very important. When to consider blood transfusion if the patient is having ongoing bleeding and the hemoglobin is less than 7 grams. So again, here I will say for a few non-technical points, yes, at the time of putting second IV line, we send the blood for the all LFTs, the coagulation profile. But in most of the setting, it takes around half to 1 hour, which after the passing of the golden period. So the quick estimation of hemoglobin by HemoQ method give you fair idea that how much patient has bled and how much time you have. So if it is around 7 grams, this is time that we organize for the blood transfusion. And always think for the coagulopathy as well, whenever there is a precedent obstacle situation like HELLP syndrome, preeclampsia, intrauterine fetal death, or amniotic fluid embolism. Bedside clotting test. When I think Dr. Leela, senior person must be knowing that how our senior people taught us that you put the blood into the test tube and see that clot is formed and that clot is strong or not. Now we talk of the thromboelastometry, which is crores of rupee and even not available, not at all in the labor room and the obstetrician cesarean operation theater. So the simple test we have to retain, and we have to give this simple knowledge to our all trainees that in the situation of crisis, you can easily have a fair good idea what is the fibrinogen level and patient is going to the fibrinogen depletion and the coagulopathy. Massive blood transfusion protocol, when it is start, again, I emphasize that it is after 3 to 4 units of PRBC has been given. It is not right from the beginning. So initially, when the patient is having PPH, it is the 3 or 4 units of PRBC. When it is not the bleeding is ongoing, then the massive transfusion blood protocol start, and then it is 1:1:1 or 2:1:1. So this is important, and whenever there is a chance of coagulopathy, then we have to have the blood component accordingly. What we want to achieve with the blood transfusion, that is all hemoglobin 8 gram, platelet count 75, prothrombin less than 1.5 into mean control, and a good vital stability. We have to be ready with our all PPH trays and with the long work as say Motherhood Committee, Dr. Sheila Manevi have really trained, and in our Manyata session with this, Rajasthan is very, very important part. We have to be ready with tray and all trays so that the time is not lost, and we have to record all parameters, what you have done, what fluid, what drug, what senior person, second opinion, and ongoing communication to women, attendant, colleague in a very cool and the composed way. And it is Manyata, what I was saying, that we are reaching to the smallest peripheral nursing home and the units and training, and that is creating a wave of confidence among them that how they deal with the obstetrical complication. Treatment of cause is very important. At Tony, we have covered retained placenta MRP, uterine inversion. You have to be very, very careful, and the laceration you have to repair. So whenever there is a bimanual uterine compression, we have to train. Important thing is that these are all temporizing measures and the right technique, that is close thumb, putting the thumbs into the anterior fornix and the thumb is outside. There are few this obstacle, simple measure which we have to deal. SR Dr. Samartha Ram is with us, and he will be like taking a lot, speaking about the SR cannula, and we have to take very wise and timely decision when you want to explore genital tract, how to repair cervical tear, and our own innovation, Dr. Pally, the very important innovation, that is transvaginal uterine artery clamp and the aortic clamp. Timpano, Dr. Nalini Mishra, and many people have innovated so that we have the drainage channel. So important thing is that we have all these things, Foley's catheter, SR cannula in our labor room, so that when we need it, they are with us, and our nurses are trained how to make a uterine tympanode. Whenever there is a possibility of retained placental piece of placenta, we have to take quick decision for the MRP, because the real difficult part about MRP is decision to undertake it. So we go on waiting, and suddenly patient collapse and become critical, and then the all chaos start. Always look for coagulopathy. I emphasize, along with the precedent obstetrical situation, medical disorder like SLE and viral infection, malaria, we have to think and take right decision. When you want to put into the operation theater, you want to shift, there are few points where you don't have to wait for the surgical exploration. When uterus is flabby, lost, pouring blood with the unstable hemodynamic status, you are not able to look for the cervical tear, where is the edge, indefinite contour of uterus, you are feeling lump abdominally like broad ligament hematoma or rupture of the uterus. This is the time that you shift the patient to the OT, take all temporizing measure while shifting to the operation theater, so that your anesthetist does not get the patient into irreversible shock. We are all going to have all wonderful video session ahead. So finally, we have to save lives, and the drastic situation need aggressive measures, set protocol, take timely decision, prepare team of friends, prepare a good team, and if you need the second level and the third level measure, take timely action and keep good communication and your cool even in worst of circumstances. So if you can fill the unforgiving minute with 60-second worth of distance, run, because it is PPH. With this, I seek your everybody's full-hearted support for my Foxy presidential candidature. I am ready with my vision for women health in our country and for fellow obstetrician and gynae to save our all OB-GYN from all sort of violence and medical legal. I request that everyone vote and support. The election will happen from 1st August to 10th August, and hope we will shape our vision together. Thank you very much for the patient listening.
I would request our chairperson, Dr. Sunita Agarwal, madam, to give her inputs on ma'am's talk.
Ma'am, talk on PPH. It is a very excellent talk. Very excellent talk on PPH. Every point is very clear, informative, interactive, and ma'am cover every point on PPH, medical management, causes, and ma'am, I bless the God for ma'am elections and for victory of madam. So we will get such a brilliant academic teacher or president for Foxy. So I think T is very important in PPS. T. 4T, too late, too little, timely intervention. So ma'am's tips and tricks, I think will help in every patient survive and thrive. Thank you, ma'am, for such a nice talk.
Thank you so much,
Our
ma'am.
blessing is with you.
Thank you so much. We invite inputs from Dr. Prakash Jain. Sir, are you there? Dr. Prakash Jain. I think sir has left. He had joined, but at present I can't see his name. So,
Devyani, Dr.
okay.
Devyani.
So we should sum up this session. Thank you, speaker and chairpersons, for such a wonderful talk. Now, moving towards the next session, it is a video demonstration by Dr. Samarth Ram sir, who is Director HOD, Sandhya Ram Hospital. And for this session, I would like to invite
Just a minute, Babita. There is one comment that my slide was visible now. During
Yes,
my
ma'am.
talk.
Was visible.
Sunita
No,
and
no,
Dr.
slides
Devi.
are not visible.
Because
Yeah,
Dr.
ma'am,
Devi.
yeah. हाँ जी मैम, yeah.
क्या स्लाइड्स विजिबल थी या नहीं?
थी मैम,
आपकी
बहुत
slide
अच्छी,
visible नहीं
very.
थी।
Madam, slides visible थी.
हाँ, yes ma'am.
Dr. Dilip
Because-
Sarangi is with us from Odisha and she says
No, no.
actually.
No, it is
Slides
clear.
are not visible,
Clear,
ma'am.
clear ma'am. Everything
It was
was
clear.
clear.
Saiti, please look into it.
Okay, ma'am.
Slides are visible, but your slides are not visible at all.
Might be local net problem.
Ma'am, to us it was clearly visible. Could be some local network problem, I think.
Okay.
Shall we move towards the next session? So for this session, I would like to invite our esteemed chairpersons, Dr. Charu Johari. She is Center Head and Consultant Infertility Specialist, Indra IVF Alvar. She has got a fellowship in ART in Reproductive Medicine, received gold medal in DGU. She's got Foxy Achievers Award at West Zone Yuva Foxy Conference and is organizing secretary of AlvarCon 23. She's joined clinical secretary EOGS, Dhira Master Trainer, and is working. She had areas of interest are infertility and recurrent pregnancy loss. A very warm welcome to you, Dr. Charu. Then we have Dr. Purnima Pachari. Madam is a renowned obstetrician and gynecologist practicing in Ajmer. A very warm welcome to our chairpersons. And I would request Dr. Charu to introduce and invite Dr. Samarth Ram.
Thank you, ma'am, for your kind introduction. Good evening, all. And now we'll have a video presentation by Dr. Samarth Ram on SR cannula for atonic PPH. As ma'am told, she is a sir is a director and HOD of Ops and Gynae Department, Sandhya Ram Hospital, Kerala, and he is a recipient of a very prestigious senior category award, Foxy Korean Award, and he is a 3 times winner of Dr. S.C. Dhawan Prize and also Foxy Figo Award, and he is also achiever of KFOG President Gold Medal and Yuva Foxy Award. And his PPH section cannula and oral hydration therapy to prevent severe preeclampsia could bring down MMR very significantly in Kerala, Tamil Nadu, and AP. And his publications are, he has published 26 original papers in national and international journals. And his special interest is in postpartum hemorrhage, preeclampsia, amniotic fluid optical density, and guided induction of labor. And I also want to mention that his paper on SP cannula was published in IUSR, and this paper was awarded by Foxy CS Dhawan Prize. And now the cannula got patent registered in September 2015 also. So I welcome sir for your presentation.
Thank you. Thank you very much. I'm audible to you, all of you.
Yes, audible, sir.
Share the screen. I'm very much thankful, Dr. Sadhana Gupta ji, for giving me this opportunity. Thank you very much for Charu Johari for giving me a nice introduction. Good evening, chairpersons, and good evening, everybody. I'm very happy I am covering in Pan India. Actually, Sadhana Gupta ji made SR Canvas Pan India, and today I'm very happy to be with my Rajasthan friends. I'm sharing my screen, Madhu. Able to see the screen, friends? Hello.
Yes, sir.
It's visible.
The title of the topic I'm presenting: SRPP suction cannula for the management of atonic postpartum hemorrhage. Greetings from God's own country, Kerala. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. Around 50% of the mothers die due to atonic postpartum hemorrhage. When conservative methods like uterine massage, uterotonic drugs, and balloon tamponade fail, surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Many times, mothers die on roads while being transported to higher medical centers. This is the SRPP suction cannula which I have developed, measures 23 centimeters long. This is the fundal portion having round, large holes. Cervical portion is having smaller holes. This is the vaginal portion, do not have any holes. This is the nipple of the cannula which stays outside the vagina and to be connected to the suction machine through tubing like this. Coming to the mechanism, how it acts. This is atonic flabby uterus bleeding, cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction to stop bleeding. Here I'm showing the uterus here. Inside this uterus, there's a cannula working, which is creating a powerful negative pressure. This negative pressure creates a global constriction of the uterus that is both in the upper and lower segment. There are coarse ridges on the surface of uterus, both on lower and upper segments. This is the reason why this cannula is very effective to stop bleeding, even in case of lower segment bleeding with the placenta previa. Once again, I would like to repeat, SR cannula is very effective to stop lower segment bleeding in case of placenta previa. Achieving closed uterine cavity is a basic and fundamental requirement for the functioning of suction tamponade system. 5 different sizes of cannulas are made to match different cervical dilatations and to match different uterocervical lengths. Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. If it is not possible to achieve closed uterine cavity with a single design of cannula. This is a post-abortal uterus. The uterocervical length is small, less, and the cervix admits only 1 finger. In such a situation, you have to use a thin cannula. Is a postpartum uterus immediately after delivery. The cervix is about 10 centimeters dilated, and you have to use a larger diameter cannula. If you use a thin cannula in an immediate postpartum uterus, this thin cannula, the uterus cervix cannot grip it, and it is difficult to form a closed uterine cavity, and it fails to stop bleeding. These are the cannulas designed for atonic PPH after vaginal delivery. This is the lateral view and this anteroposterior view. Thin cannula is meant for cervix admitting 1 finger, and this larger diameter cannula is for prophylactic application and immediately after application with dilated cervix. These are the cannulas, short cannulas designed for application during cesarean section. Thin cannula is meant for cervix admitting 1 finger, and larger diameter cannula is meant for dilated cervix. This is the cannula designed for bleeding after MTP and vesicular molar extraction. The hole index is different, and the cannula is also used as a suction tube introducer in a case of cesarean section. When compared to balloon tamponade, in balloon tamponade, the mechanism is totally opposite. Here, the water-filled balloon dilates the uterine cavity, and the distended balloon compresses the bleeding sinusoids to stop bleeding. On the other hand, the vacuum tamponade system assists the natural physiological process of contraction and retraction to stop atonic bleeding. SR cannula application for atonic PPH during vaginal delivery. I am showing a video here.
Woman bleeding profusely.
My videos are seen well. Audible?
Yes, it is visible.
Thank you.
Yes, sir,
Thank you.
it's audible.
White blood speck like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be fed bimanually Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. We can see complete cessation of bleeding within 4 minutes. Retracted well.
Application of negative pressure. A negative pressure of 650 millimeters mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be applied by just switching on the machine. Then the question is, how long to keep the cannula inside the uterus? Usually, the cannula can be removed after 6 to 8 hours. In case of high-risk women, cannula can be kept inside the uterus as long as the bleeding expected, even after 24 hours. Whenever there is a recurrence of bleeding, just we can put on the machine. This how long to keep the cannula inside uterus, how long you should apply negative pressure is at the discretion of the obstetrician. If the obstetrician feels that the woman may not bleed, he or she can remove the cannula. And suppose before 1 hour, if the woman starts bleeding again, you can just put on the machine and create negative pressure to stop bleeding. SR cannula application for atonic PPH during cesarean section.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with a thin long cannula. As this is an elective section, I am dilating this cervix with index finger. I use thin long cannula, which I call it as a number 5 cannula, as a suction tube introducer. Suction tube should be connected to the suction machine. Cannula should be kept in proper position like this. Cut edges should be kept close together. Mop pressure applied. Negative pressure applied. You can see complete cessation of bleeding, contracted and well retracted uterus. You can see practically no bleeding. I am closing the left angle under direct vision. Contracted and retracted uterus. Blood loss less than 100 ml.
One thing I would like to make it clear is to apply negative pressure, you need not suture the uterus and then apply negative pressure. You have to just keep the cut edges close together and put a mop to seal the wound and apply negative pressure. Because of the negative pressure inside, just like a valvular mechanism, the cut edges come close together and it forms a closed uterine cavity and the uterus starts shrinking. Virtually, you can see how the uterus shrinks under negative pressure inside the uterine cavity. Prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH like PIH, anemia complicating pregnancy, and accidental hemorrhage, and so on.
For prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blood speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta without wasting any time. Left two fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers. Tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml. Uterus retracted well.
SR cannula for traumatic PPH. I suggest to apply SR cannula for every case of PPH, whether it is traumatic or atonic. In a case of advanced traumatic PPH, some amount of uterine atony is always possible. Cannula corrects its atonic component and reduces bleeding. When negative pressure applied, cervical tissues get compressed firmly on cannula and stops blood flow in descending cervical vessels. If you apply traction on the suction tube with left hand, entire uterus along with the cervix descends down. You can apply speculum under good source of light, visualize the tears, and you can suture the wound in a bloodless field. And here we don't use sponge holders to explore the cervix because it is well seen because uterus and cervix descends down. SR cannula for transporting the woman with PPH. SR cannula is very effective for transporting woman with PPH to higher centers. Here we use this manual suction pump. This device doesn't need electrical power for operation and is equally effective and can create negative pressure of 650 millimeters mercury within 1 minute time. And this is useful when there is no power and also useful when during transport in the ambulance.
Manual suction pump can also be used to create negative pressure inside uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula.
How to remove SR cannula after the procedure? After the completion of the procedure, the cannula cannot be removed easily as the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Cannula can be removed easily.
Cannula can be easily removed after gentle separation of these adhesions with finger manipulation like this.
This is a cesarean section we have done last night, and morning we are removing the cannula.
Are you able to see now?
We have to insert the finger in between cervix and the cannula and sweep around the cannula and detach the stuck tissues into the holes of the cannula. Once the tissues are detached, the cannula come out easily like this. How to clean the cannula? Some people are asking a question like this, sir, it is difficult to clean cannula.
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Then the question is whether the SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but with SR cannula, you can treat the inversion of uterus. What we have to do here is you have to reposition the uterus into the abdomen. We have to insert the cannula and apply negative pressure. The atony will totally disappear and uterus becomes a rigid organ and it will not descend further. Cannula is also effective to stop uterine bleeding even in case of coagulation failure. It's a case of cuvular uterus with coagulation failure, and we have inserted cannula and applied negative pressure. We could stop bleeding and we could save the mother and her fertility function. Further, if there's any difficulty, I have given my number on the cannula itself. You need not search in your cell phone. You can call me. I'll come to your rescue. Under care of Government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe pre-eclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh from July 2018. This oral hydration therapy is again my innovative work. Hands-on training workshop was conducted at District Hospital Chittoor. Suction cannulas are provided to all institutions conducting deliveries like PHCs, CHCs, area hospitals, and all medical colleges. ANMs and ASHA workers were assigned the job of oral hydration therapy to all antenatal mothers to prevent preeclampsia. Oral hydration therapy is nothing but making every antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. In peripheral centers with suboptimal facilities, we advised prophylactic application of SR cannula to all women, both in case of vaginal deliveries and cesarean sections. Here I'm giving the 3 months report after application of SR cannula in Chittoor district. You can see here 8,396 deliveries occurred and 1,500 applications of SR cannula were done in 3 months period, and 429 vaginal applications and 1,074 vaginal applications, 429 cesarean applications. You can see here, not a single maternal death occurred due to PPH. Another important observation, only 28 units of blood was given for 8,000 and odd deliveries. The blood transfusions come down drastically. 5 years performance of OHT and SR cannula to bring down MMR in Chittoor district. Here we have introduced SR cannula and OHT in the year 18 August. So 18 August. You can see here 47 maternal deaths occurred between 17-18. Now 22-23, only 9 deaths occurred. 47 deaths come down to 9 deaths. And hemorrhagic deaths, 9 deaths were there between 17-18, and 0 deaths occurred for entire year. For 30,000 deliveries, not a single maternal death occurred in the entire district. And here you can see here the MMR 88, 94, 90, previous to SR cannula introduction. The 83 MMR dropped to 33.3. It is a very, very significant achievement. And I would like to show another important observation here. See, this PIH deaths were 16, 17, 18, 16 deaths were there. Last year, for entire year, only 1 maternal death occurred due to PIH. And what I would like to say, oral hydration therapy is very effective to bring down maternal mortality due to pregnancy-induced hypertension. The significant reduction in MMR is due to the combined effect of SR cannula and OHT. Now entire Kerala, Tamil Nadu, and 80% of Andhra Pradesh, many major hospitals in Karnataka are using this SR cannula to prevent and treat PPH. Kerala Federation had included this device in its obstetric protocols to prevent and treat PPH. If you just observe the MMR in South India by the Government of India reports, there is a drastic reduction of MMR in South Indian states. 22% reduction in Andhra Pradesh, 36% reduction in Kerala. You can see MMR in Kerala dropped to 19, which was never before. SRPP suction cannula is a breakthrough innovation to prevent and treat atonic PPH. There's a prodigious shift in the management of PPH now. The panic adrenal rush of the obstetrician had gone with the introduction of SR cannula. This is a simple, cost-effective, life-saving and fertility-saving technique. This is a physical method, does not depend on biological factors for its action. There's no need to maintain cold chain. For the same reason, it doesn't fail. Suction cannula system can be organized within 2 minutes time. Bleeding stops just within 2 to 3 minutes. Cannula system works well even in case of coagulation failure. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable and reusable instrument. Helps to reduce maternal mortality due to atonic PPH in low resource settings. Every delivery point in the country should have SR cannula, and it should be used as a first defense, not as a last desperate resort after failure of all other methods. No child should become motherless in this country. We should achieve a PPH-free India. Thank you. Thank you very much.
Thanks.
Hello.
I would invite inputs of our chairpersons. Dr. Purnima. Okay,
Yeah,
Dr.
hello, Dr.
Charu, you can
Charu
sum up
here.
the session.
Yeah, Dr. Charu here. So thank you, sir, for such a beautifully demonstrated video, and all the steps were very clear by you. And definitely, with the help of you, we'll also decrease the MMR of our states also. And thank you for your nice input, sir. And definitely, these videos are going to help us in future for dealing with PPH. Thank you so much.
Thank you very much for a nice comment on my talk, and I'm ready to work with you to bring down maternal mortality in Rajasthan and northern states. If you invite me, I will definitely come, and I'll conduct hands-on training workshops. We can do wonders there.
Yeah, sure, sir. Thank you, sir.
So that was indeed a wonderful session. Thank you, speaker and chairpersons. Now moving towards our third session, it is a video demonstration by Dr. Shashi Kabra Maheshwari, Madam. She is President of Delhi Gynae Forum Southwest. For this session, I would like to invite a chairperson, Dr. Prerna Rathod. Madam is she has done a post-graduation from SP Medical College, Bikaner, and is in government services, different places from 1984 to 2001, and took voluntary retirement as junior specialist in 2001, established in Mahavir Hospital and Maternity Center, Hanumangarh. She is Secretary IMA Branch, Hanumangarh in year 2016 and Secretary Foxy Branch. Very warm welcome to you, Dr. Prerna. Then we have Dr. Nikita Tareja. She's President of Ganganagar Ops and Gynae Society and Director of Thareja Hospital and visiting consultant Medanta Hospital. A very warm welcome to our chairpersons, and I would request Dr. Nikita to introduce our speaker, Dr. Shashi ma'am. Dr. Nikita,
Good
are you
evening.
there? Okay.
Yes, good evening. Can you hear me?
Yes, you're audible.
Good evening, esteemed members. It's a very nice session, and I'm really thankful to all of you to make me a part of this session. I feel really good to introduce Dr. Shashi Kabra, who is MD, FICOG, FSCH, FMAS, and a number of degrees under her name. She has had IMA Appreciation Award in 2018. She is recipient of Wonder Foxy Award in 2019, APJ Abdul Kalam Appreciation Award in 2020, IMA Karamveer Award in 2021. She has been Champions Award of Critical Care 21, APJ Kalam Excellence Award again in 2022. She has had Asia GCC Award Quality Leader Healthcare in 2021, Rashtriya Gaurav Award in 2021. She is a national mentor at Lakshya in association with AIMS Delhi and WHO. She is member of Practical Ops and Gynae Committee, FOXY, and she is Medical Education Committee, FOXY. She has organized more than 65 workshops on PPH all over India. It is my pleasure to invite Dr. Shashi Kabra for the talk. Dr. Shashi Kabra, please take over. You have to unmute yourself, ma'am.
Thank you so much, Dr. Nikita, for such a kind introduction. And I have a special relationship with Rajasthan. I'm a born Rajasthani Marwadi, and I was born in Sikar, and I did my initial schooling in Losar, which is a small town in Rajasthan.
Yeah. Rajasthan people are shining like anything, na?
Yes, yes, yes.
That's right.
Even Dr. Sadhna, Dr.
Yeah. So can you see my screen?
Yeah.
Yes, ma'am.
So, whenever we talk about surgical management in postpartum hemorrhage, I always say that you remove the word nightmare from your dictionary. PPH is no more a nightmare. You develop that expertise and skills to defeat PPH. So this is a very old picture, a copyright of Dr. B. Lynch. Here you can see that this is the LSCS incision, and we apply uterine artery ligature, one upper and one lower. And This is the ovarian ligament. At the medial aspect of the ovarian ligament, here in the broad ligament, we apply sutures on the anastomosis of uterine and ovarian artery. We do not ligate the ovarian artery, which is here. We ligate here. So showing you a video because mine is a video session. So this is uterine artery ligation. Joints is in place, bladder retracted down. Palpating the uterine artery. I either use number 1 Vicryl or catgut. As I mentioned, 2 centimeter of myometrium taken from anterior to posterior. Fan out the broad ligament. Take out the needle through the vascular area from posterior to anterior. The suture material which I use is Vicryl, number 1 or 10 or catgut. So tying the knot securely, I take 2 turns in the first knot and then each knot in successive knots in reverse direction to make it a complete surgical knot. I have a lot of faith in applying the 2 turns in the first knot. In all cases, I apply like this. Now, distal ligation is done 2 to 3 centimeters below the first one. Same procedure. Anterior to posterior, taking a chunk of the myometrium around 2 centimeters and then making seeing a vascular window in the broad ligament and coming from posterior to anterior. So the tying method, the knot tying method is same. So I can move to the next video. This is a video of the anastomosis of uterine and ovarian artery. And this ovarian artery word is a misnomer, as I've already said. And this was shared by my colleague, Dr. Soma. So you see here, our point of ligation is here. We are taking a part of myometrium, going from anterior to posterior. The bite should be here, not here, because it will bleed at the level of the corn. So the video is self-explanatory. I'm going from posterior to anterior, and between the 2 bites, there lies the anastomosis of the uterine branch of ovarian artery and ovarian branch of the uterine artery. So this is how we have taken 2 turns in the first knot. This is how the ovarian artery is ligation. Similarly, it is done on the other side. So now the final thing, internal iliac artery ligation. And when I was doing surgeries in earlier days, then I used to feel that internal iliac artery is very important because I saved many patients with this. And later on in 2022, FIGO has recommended this in their guideline on PPH that every obstetrician should learn internal iliac artery ligation. So proceeding with this is abdominal aorta. At the level of L4 and L5, it divides into 2 common iliacs and it makes an inverted Y here. And this then successively each common iliac divide into 1 external iliac artery and internal iliac artery, and they make another inverted Y. So we are concerned with these 2 inverted Ys which lie laterally, not in the midline. When you take an inset of this diagram, then this is one-sided common iliac artery. This is right side. This is lateral side. This is medial side. This common iliac artery divides into external iliac artery and internal iliac artery. And the internal iliac artery is a medial and posteromedial structure. And immediately after its origin, it gives the posterior branch. And we have to ligate the anterior division because the uterine artery is a branch of anterior division along with vesical and vaginal artery. In a pool of blood, we cannot see this posterior branch. So we measure a distance of 4 centimeters from the origin of internal iliac artery and we ligate it here. So how internal iliac artery works? Bilateral internal iliac artery ligation results in 85% reduction in pulse pressure, 50% reduction of blood flow. Basically, initially it is little difficult technically, but the learning curve is not like in laparoscopic surgery. One can do after 4 or 5 cases. So this is a life-saving procedure. That's why it is very important that FIGO recommends that this procedure should be learned by everyone. So these are my 2 companions in performing internal iliac artery ligation. This is called mixture forceps or right angle forceps. This is bent at right angle. And another thing is this thread, which I make double. That's why I called it double thread. This diagram myself made. I use either number 1 silk or Vicryl, 1 preferably, and if 1 is not available, I have even used 10 Vicryl, but most of the time I use number 1 silk. So this is a small video. When I was teaching, when I was doing internal iliac artery ligation, then my residents were not able to assist me properly. So then I thought the need of making a model for them so they can at least understand the anatomy of internal iliac artery ligation. So this is a model which I made myself. And excuse me, I think I have to stop share and I have to reshare because I have not connected with sound. So I'm doing this. I'm sharing screen again. So just please tell me that sound is coming. This is common iliac. Is it coming? Hello, Dr. Babita, Dr. Nikita. Is sound coming?
Yeah, we are able to hear.
Audible.
This is external iliac artery, which is later on continued as femoral artery. Audible, na? This is internal iliac artery, and we have to ligate. Hello, sound is audible?
Yes, ma'am, it's audible.
Okay. The anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally, in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters. This is the place where I can recognize the internal iliac artery needs to be ligated. This is right angle forceps, also called mixture forceps. It is bent at 90 degrees and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral to medial, and gently I will open it, the loop, and I will get hold of the loop, and just gently I will come out like this. So now you understand that very, very gentle. Now next step is I will cut this and make 2 threads. Thread, and this is another thread. See, this is plain and this is another thread. So look at the technique of applying ligature. I have taken hold of one ligature. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn, and I have tied it here. Then very gently I applied the second throw, and again very gently I applied the third throw. Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I'll cut this. And just. So this is a very easy method of teaching them anatomy, and actually what procedure we are going to do. This is common. So now, as I've said initially, that this is a life-saving operation. Now you see that in this case, how it saved the life of the woman. This was a 26-year-old primary gravida with full-term pregnancy, booked initially in one facility. Then she had ANC at Anganwadi Center, and she started having labor pain on 23rd November and rushed to 3rd hospital at night. She went into obstructed labor, taken to another 4th hospital, where she had undergone emergency cesarean section for second stage arrest and the spinal anesthesia at 8 a.m. in the morning. And then she had an episode of PPH at 10:15 a.m., which was managed medically by the doctors over there. Then she had another episode of PPH at 12:30 p.m. and she developed shock. That time, the doctors took her to operation theater and left lateral cervical tear was repaired along with the posterior vault repair. By that time, she received 4 units of PRBCs, 4 units of FFP, and 2 units of platelet. That means total 10 units of blood clot she already received. Then again, she became stable and doctors went to their OPD. And again, when they come back at 7:15 p.m., that is after 11 hours of delivery, the patient went into shock again. Patient was resuscitated and referred to me with 5th unit of PRBC on flow. When we received the patient, her pulse was 146 per minute, though it seems that her BP was normal, 104/60, but you see her shock index, 146 divided by 104, was more than 1.2, and that means the patient is in shock. So I did not waste even a single second in taking this decision that I have to open the abdomen, and so I opened the abdomen. So this is what could I see? Hemoperitoneum posteriorly, which could not be appreciated from parabdominal examination, and there was a huge broad ligament hematoma reaching up to the whole of colpos on both the sides. So I performed an obstetric hysterectomy in this case. One side uterine artery was retracted and could not be seen. And there was slight oozing in the pelvis. So I performed an internal iliac artery ligation. And this is an unedited video which I'm showing to you. So just see this. This is the round ligament ligature. Below the round ligament, I'm trying to open the peritoneum. We call it opening the retroperitoneum, the broad ligament peritoneum. I'm moving slowly, laterally, parallel to the infundibulopelvic ligament and reaching up to the lateral pelvic wall. I cut it for around 5 centimeters. I think you can appreciate it, that very slowly, gently, I'm opening the retroperitoneum, taking care of underlying structure. Now I kept my all instruments and only with fingers, I'm separating the luge areolar tissue. You see, this is ureter in the medial flap. This is internal iliac artery, and this is medial side. Ureter in the medial flap, internal iliac artery, external iliac artery, and common. This is common iliac, this is external iliac, this is internal iliac, this is ureter in medial flap. Internal iliac, external iliac, common iliac, ureter in the medial flap. And what I have said, that you have to recognize the structure very well. So this is the inverted Y I am talking about. Very well delineated structures. This is internal iliac artery. This is lateral side, external iliac artery. This is common iliac artery. Now I am pressing the external iliac artery and feeling the pulse in femoral artery, which is changed. And again, I am pressing the internal iliac artery. There will be no change in the femoral pulse. So this is how I doubly confirm that this structure is internal iliac artery. Now I know that the ligature place is approximately 4 centimeters, my thumb length from the common iliac artery. And now just see the dissection. The artery and vein are enclosed in a sheath, and I'm separating the sheath very gently to make a place for insertion of my mixture forceps. See, this is a thin layer of sheath enclosing the internal iliac artery and vein, which I'm cutting and trying to make a window over here. This blue structure behind is internal iliac vein, and just see how I'm saving it. This blue structure is internal iliac vein. This is a mixture forceps. It is not sharp. So I made a place for this. Now I will go from lateral to medial. On both the sides, we have to go from lateral to medial. This is the vein. This is the artery. The loop is already ready. Double thread. Very gently, I've taken it out. You have to be very gentle. कहते हैं कि दिमाग एकदम बर्फ की तरह ठंडा रखो, आइस की तरह, खीरे की तरह नहीं, बर्फ की तरह ठंडा दिमाग में रखती हूँ इसमें. I've cut the loop. or I have made 2 threads. The purpose of making 2 threads from 1 thread is this, that you pass mixture forceps only once, and that saves injury. That decreases injury by 50%. Now I'm separating the thread as I've shown in my model, which one is playing with which one. I've recognized which thread is playing with which one, and now I'm trying to put knot. Just see, I will be taking 2 turns in the first knot. That is very important. And I'm bending my back, bowing my head in front of the artery, and with my fingers, I'm placing the knot just on the superior surface of the artery. I'm not pulling the artery. This is a very important method which I want to teach you. And now I'm applying the successive knots. So never pull the artery. You bend your head in front of the artery. Artery को salute कर दो कि तुम body की third biggest vessel हो. So you are great. So now you can see that the ligature in place. Now I will apply the second ligature, 0.5 to 1 centimeter away. You can appreciate the gut over here. 0.5 to 1 centimeter away, I will apply the second ligature. You just see the first ligature is seen. Same method. Double turn in the first knot. Make the knot square. Placing the knot on the artery, 0.5 to 1 centimeter away from the previous ligature. You see, you can appreciate a bulge between the 2 ligatures. And this is around 0.5 to 1 centimeter. And you can here see that the artery has been properly tightened. So this is internal iliac artery ligation. We apply 2 ligatures and we never cut in between. And this completes internal iliac artery ligation. You can see this is the ligature of internal iliac artery. This is external iliac artery. This is common iliac artery. Okay, and this is ureter in the medial flap. So the very important precaution is this right angle clamp should be taken from lateral to medial, because if we take it from medial to lateral, then this will hit the external iliac artery of that side. So we have to prevent injury of that. So I have been working in Deendayal Upadhyay Hospital since last 22 years, where the annual delivery rate is 10 to 12,000 per annum. And whatever I learned, I thank my hospital very much for training me. And whatever I learned by doing 104 internal iliac artery ligations in last 22 years, that I am sharing with you. What are the important tips? I have not, as I always say, I have not copied it from any of the textbooks. These are my own findings, which I want to share with you, that when you open the retroperitoneum for the anterior approach, you open below the round ligament. If the uterus is there, then you make a nick in the round ligament and open the peritoneum and go laterally. And if uterus is already removed, I've shown you, then you also go laterally through the point and go towards infundibular-pelvic ligament parallel to it. And if you are opening from the posterior approach, then you push the uterus anteriorly 2 centimeter below and 2 centimeter lateral to the sacral promontory. On both the sides, you open the retroperitoneum, make a nick and open it. Then, as I've already told you and shown you, that when you remove all the instruments, once you open the retroperitoneum and only do finger dissection, do not keep any instrument in the vicinity. This will save injury on the great vessels lying over there on the psoas muscle. Then this is very important point. Next step is locate bifurcation. That means locate the inverted Y, which I was talking about, and I've shown you inverted Y in my video very well. And then recognize internal iliac artery as a medial structure, not causing any change in femoral pulse. When you press the external iliac artery, it will cause change in femoral pulse. Then the movement of mixture forceps or right angle forceps always from lateral to medial, never the reverse. Then careful knot tying in the cavity, as I have shown you, 2 ligatures 0.5 to 1 centimeter apart. And last but not the least, this is a very important line, always do bilateral, because the literature says that the chances of free laparotomy and morbidity increases when we perform unilateral ligation. And I too have seen in my own hospital this 5-6 times. So thank you so much. Thank you, Sadhna ma'am, Dr. Babita Shukla ma'am, and Dr. Ayushi Agarwal, and all the societies, presidents and secretaries and societies of Rajasthan for giving me this wonderful opportunity. And I seek your valuable vote for ICOG Governing Council membership, which I'm contesting this year.
Thank you so much, ma'am. Watching your video is always a pleasure. Again, I request our chairperson to conclude this session. Dr. Nikita, are you there? So, can't see her now. She was there earlier. So let me do the honors, ma'am. As usual, your session was really wonderful. Internal iliac ligation, I call it a showstopper. Everyone should know it because it really, really works, as you say. We are not very confident. Yes, I mean, we'll try opening it in non-gynae cases till we gain confidence, I feel. Thank you so much, ma'am.
Thank you.
So,
Thank you.
moving towards our panel discussion, I would like to invite our moderators for the session, Dr. Dolly Mehra. She's consultant obstetrician and gynecology, Mehra Nursing Home, Ratlam. She's president, Ratlam Obs and Gynae Society, organizing chairperson, MP State Conference, AMPOGS, Zonal Coordinator, FOXY 2019-20, Joint Secretary, MPOGS 2019, faculty in various national and state conferences, author, various obstetrics and gynae books, and peer review of Jogi. She's recipient of several awards like the Champions FOXY Award, Dr. Dhruv Shah Youth Trophy for Best Activities in Adolescent Health, to Ratlam Obs and Gynae Society, Wonder FOXY Award, Champions of FOXY President's Appreciation Award, Nari Swasth Pehal FOXY Appreciation Award, and Special Appreciation by FOXY Adolescent Committee and FOXY Public Awareness Committee. That's really very impressive, Dr. Dolly. A very warm welcome to you. Then we have Dr. Aditi Rathore. She's consultant Rathore Nursing Home, Jaora. Her work, she's member organizing committee EMOGS 2018 and secretary ROS at present. She's recipient of PMSA Award 2019. She's speaker at national and state conferences and participated in various webinars. Her areas of interest being obstetrics and fetal medicine. A very warm welcome to you, Dr. Aditi. Now, we invite our expert panelist, Dr. B.S. Jodha. Sir is senior professor at Medical College, Jodhpur. His recipient of awards, his awards and achievements are: he has done his diploma in gynae endoscopic surgery from France, trained in ultrasound, ART, fetal medicine. He's secretary of Jodhpur Obs and Gynae Society. He's recipient of Marwar Achievers Award 2015. He's postgraduate and undergraduate examiner in various universities, paper setter in university exams, and review editor for journals. Sir is national master trainer of various government-sponsored programs, and he has various publications in national and international journals. A very warm welcome to you, sir. Then we have Dr. Suchitra Narayan from Ajmer. He's worked as assistant professor in GLN Medical College, Ajmer, and in Lady Harding Medical College, Delhi from 2015 to 17. Then associate professor at Lady Harding from 2017 to October 2017. Again, assistant professor, GLN Medical College. Her areas of interest being high-risk pregnancy and gynae oncology. She has published papers in national and international journals. A very warm welcome to you, Dr. Suchitra. Then we have Dr. Monica Gupta. She's HOD and senior consultant, Dutch Hospital, Alvar. She's trained hysteroscopic and laparoscopic surgeon, recipient of several awards, the West Zone Public Awareness Committee. She's West Zone Public Awareness Committee Coordinator, organized president of AlvarCon, past president of Alvar Obs and Gynae Society. She is Dhira Master Trainer, Manyata Assessor, founder secretary of Alvar Obs and Gynae Society. She has received Times of India Award and Rajasthan Gaurav Award in Public Awareness. She's editor of Foxy newsletter Alwar. Her areas of interest being high-risk pregnancy and pregnancy with medical complication. A very warm welcome to you, ma'am. Then we have Dr. Taru Chaya. She's director Bansal Hospital, Shamnagar, Jaipur. Visiting consultant, Cocoon Hospital and Surya Hospital. She is member of Foxy Breast Committee and the areas of interest being high-risk pregnancy and uterus conservation. That's really very nice. Next, we have Dr. Akriti. She has done fellowship in minimal access surgery, consultant at Harish Hospital, Alwar. She has experience in laparoscopy and hysteroscopy surgeries and worked as secretary of Alwar Obs and Gynae Society. Very warm welcome to you. Then we have Dr. Shubhra Singh. She's consultant in Daffodils and Runta Hospital, Jaipur, visiting consultant in EHCC and Eternal Sanganer. She's done a fellowship in minimal access surgery, member of various associations. She has worked in Eternal Heart and General Hospital, Jaipur, and also in Global Heart and General Hospital, Jaipur. She has papers and video presentation in national and state conferences, paper publications in journals. She has got second prize in IMS quiz. She's Foxy certified ultrasound training course from Sri Ans Fetal Medicine Center and also laparoscopic operative workshop, Foxy certified laparoscopy operative workshop in Jaipur in 2019. A very warm welcome to you.
Thank you.
Then we have Dr. Savita Bansal. She has worked as senior registrar in Obs and Gynae Department and Fetal Medicine Unit, Apollo Hospital, New Delhi. Worked as consultant Obs and Gynae and Fetal Medicine at Cocoon Hospital, Jaipur from 2012 to 14. She has special interest in fetal medicine and prenatal diagnosis and high-risk pregnancy management. She is trained in genetic counseling, level 2 prenatal ultrasound scan, and prenatal diagnostic techniques like CBS, amniocentesis, and photosynthesis and fetal detection. So, very warm welcome to you. Now, I hand over the session to our moderators, Dr. Dolly and Dr. Aditi.
Thank you so much, Dr.
Very
Babita.
brainstorming session now.
Thank you so much, Dr. Babita. Thank you to the organizers for giving me this opportunity. And I wish Dr. Sadhana Gupta all the best for her future endeavors. Pranam to my guru, Dr. Veena Acharya, Dr. Leela Vyas, and Dr. B.S. Jodha, who are from Rajasthan. I am from Rajasthan. My co-moderator is also from Rajasthan. So it's like, coming home for me for this webinar.
The best part is I also come from Rajasthan.
Oh my
क्या बात है
I'm a Marwadi. I come from Rajasthan. Yes.
Oh, great. अब लगता है मारवाड़ी में बात कर ली जाए.
हाँ, बिल्कुल मारवाड़ी में बात करने को मन कर रहा मैम.
है ना, मारवाड़ी में बात कर लिए. कौन जोधपुर की बोले नहीं उदयपुर की
मारवाड़ी शब्द बता दो.
विद्या कौन सी बोली बोले, उदयपुर या जोधपुर की, जो कहोगे बोलो.
मैम हम लोग इधर अलवर साइड के हैं. मेरे पापा अलवर में रहते थे.
अच्छा, चलो ठीक है. अलवर
मैम हमारे यहाँ एरिया के हो गए.
So it's like, Rajasthan get together. Right? So today
we start.
I have been given the topic of discussion of atypical situations in PPH, atypical cases of atypical case situations in PPH. The presentation is also atypical, and it will be basically what actually what we have done and what we expect, what was wrong, what was right, we expect from the panelists. So I welcome Dr. Shubchitra, Dr. Monica, Dr. Taru Chaya, Dr. Akriti, Dr. Shubhra, and Dr. Savita Bansal. So again, directly we come to the case. Case 1, Primi gravida, 32-year-old, booked and investigated patient, spontaneous conception, past history of renal transplant 3 years back, reported with leaking at 36 weeks of gestation. On examination, her GC was good, well-oriented, pulse 100 per minute, BP 150, 90 millimeter of mercury. On per abdominal examination, 36 weeks cephalic, fetal at 140 beats per minute, but the PV was one finger loose, not taken up, leaking present with meconium. And on CTG, there was the beat to beat variability was more than 10, but there were no accelerations in 30 minutes. Considering her to be a high risk because of the renal transplant and the fetus and superimposed PIH, because of meconium, she was taken up for a cesarean section. The past history, there was renal transplant 3 years back for CKD on immunosuppressants like azathioprine. Preconception counseling was done by nephrologists, proper antenatal care taken, essential hypertension with superimposed HDP managed with labetalol and nifedipine. Dopplers were within normal range and nephrology opinion was taken off and on. Her investigations, hemoglobin 10 gram, BT-CT prothrombin time and liver function tests were normal. Creatinine 1.3, blood urea 35 and platelets were 80 lakhs per minute. LSCS taken for fetal distress, AMTSL done. Female fetus delivered out with good FCAR score, kept under the pediatrician care. Care taken for proper hemostasis, post-op 30 minutes. In spite of medical management, there was bleeding and estimated loss of 800 ml. Balloon tamponade done. Medical management continued. 4th stage of labor monitored in ICU. Input-output chart maintained. 2 units of fresh frozen plasma and packed cells arranged. Balloon tamponade gradually released after 24 hours. Discharged after 4 days after doing her renal function test. So now, I would like to ask Dr. Suchitra, is pre-conception counseling justified? What is the ideal time for conception and what antenatal care should be taken in such patients? Dr. Suchitra, are you there?
Yes, I'm here. Good evening, everyone. Pre-conceptional counseling was well done in this case, as the renal transplantation was done 3 years back because of the CKD, and her renal functions were absolutely within normal range, as the creatinine was less than 1.5 milligrams and the urea creatinine, and she was absolutely fine. So it was, and she was continuously in touch with nephrologist. So I think this was well done from the nephrologist.
Okay. So now, what antenatal care, what precautions are you going to take in the antenatal period in this patient?
Her renal function test, especially the blood urea creatinine, and especially we have to maintain the sugar levels, as she is continuously on the immunosuppressives. So the glucose chances of glycosuria and the development of the towards the increasing level of sugar levels, and continuous monitoring regarding the as we are doing in for every case, or for the fetal monitoring also, level 1, 12 markers, and regarding her routine checkups and diet, especially her diet, these are to be taken care of.
So we have to take care of PIH, anemia, and GDM in these patients because they are on immunosuppressives, right?
Yes.
What care during delivery or cesarean should be taken, and what should be the threshold for the amount of blood loss? I would like to ask Dr. Monica Gupta.
First thing, they are on the immunosuppressive therapy. So we have to take care of the aseptic condition properly, because the chances of infection are very high in this type of the patient. And we can have a secondary PPH also because of the infection. So the first thing is infection. Then we have to control for the BP, and we should not give the drugs who are nephrotoxic because they are already having a renal transplantation.
Right.
And the threshold amount of bleeding, we should be very minimized. The bleeding should be very minimized. Not affect the hemodynamics of that.
Yes. So, Dr. Taru, I would like, are you there, Dr. Taru? Dr. Taru Chaya? I would like to ask Dr. Akriti, was balloon tamponade justified in this patient? And what are the types of balloons? What is the method of application? Can anybody speak? Dr. Akriti, can you take up this question? Dr. Akriti, are you there? Dr. Shubhra?
Yes, ma'am.
Yeah. Yeah, Akriti, yes.
Ma'am, I think the decision of tamponade was timely taken in this patient, and it is justified also because that is, I think we are using less drugs, as it is the patient is a compromised patient, so we should use lesser drugs. and balloon tamponade is going to give mechanical effect of help in PPH. So it is timely done and it is justified in this case. Types of balloons, ma'am, we can use Sengstack and Blackamoor tube and Bakri balloon, and also Foley's catheter can also be used. We inflate it with warm saline, and the bulb is introduced in the cavity, uterine cavity, and it is taken out through the opening, the channel opening, and it is inflated with around 400 to 500 ml of warm saline, which gives a good tamponade effect. And it also helps us to do the tamponade test, that if the bleeding stops and we are able to see that there is no more bleeding, that means tamponade test is positive and we do not need any further surgical interventions are not required. And later, after 24 hours, the balloon can be deflated to reduce this effect. And I think it is a good measure to reduce PPH in this patient.
I would like to comment upon two things over here. There is another balloon called by Dr. Thomas Brook, which is called the UBT balloon, which is cheaper than the Bakri balloon, and that can be used. And after inserting the balloon and after checking the bleeding, if the bleeding has stopped, then we need to pack the vagina also in these cases. Otherwise, the balloon is going to come down. So that also has to be taken care. So the vagina has to be packed properly in these particular patients.
Sure.
So that was fine. And according to Dr. Samarth Thamatharam's topic, you can also, we could have also done a SR cannula can have also been done. But at that particular moment, it was, it was a very quick decision, and so balloon tamponade was done. Yes. So what post-delivery follow-up and what contraception advice, is it needed or it is not needed? Dr. Savita, are you there? What post-delivery follow-up is required in these patients? Dr. Akriti, can you take this question? What post-delivery follow-up is needed in these patients, and what contraception advice are you going to give to this patient?
Ma'am, post-delivery, the patient has to be kept on a close follow-up, more than the other patients that we could do. Firstly, because the patient is a hypertensive patient, so PP monitoring has to be done even in the postpartum phase. Secondly, as ma'am has already told, secondary infection can set in, and we have to look for any secondary PPH and any kind of patient that says any kind of bleeding or foul-smelling discharge should be really taken care of. Also, ma'am, contraception is really needed for such patients. A proper gap is should be advised to such patients, because as it is, she's an anemic patient, and patient of renal transplant would need at least 2 to 3 years of, at minimum of 3 years of time to build her iron stores and also to maintain her physiological requirements. So I think contraception should be provided to such patients. And again, I would, according to me, I think an intrauterine device or would be a better option in such patients to provide a long-term contraception without usage of more drugs, and a very at least 99% of efficacy will be provided to such patient. So I think intrauterine device could be a good option for her.
Yes. Dr. Monica, you are muted. Dr. Monica, you are muted.
I think barrier methods are better for the contraception.
Yeah, ma'am.
With the IUCD, there's a little chances of infection is there. And
yes, ma'am. Long-term progesterones and barriers are better than IUCDs.
Dr. Shubhra, I would like to ask, will you do a renal function test in this patient, and at what interval?
Yes, ma'am. I would like to do a renal function testing, and ideally we should try to keep creatinine levels less than 1.5. More than 2 is also even acceptable.
Yes.
Along with that, if they are taking higher doses of prednisolones, then we need to give hydrocortisone also postpartum to these patients. IV hydrocortisone should be continued. And apart from that, they should be given thromboprophylaxis also if their prednisolone dose is very high during their antepartum period and at the time of labor. So they should be given.
This particular patient was not on steroid, and she was only on azathioprine. But if the patient is on steroid, then yes, these precautions have to be taken.
Yeah, taken. Yes, ma'am.
Right. So, so the important points are that preconception counseling is essential. Antenatal care is very important, particularly for the screening for anemia, eclampsia, GDM, IUGR, and UTI, as everybody has mentioned that there can be infection. Also, in these patients, CMV infection is common. So, you have to screen for that also during the antenatal period. Serial Doppler assessment for fetal well-being is important. Lower threshold for diagnosing PPH in such patients, because, otherwise we would say that 1000 ml in LSCS is the threshold. But here at 800 ml only, the decision of balloon tamponade was done. Vaginal birth is not contraindicated. A multidisciplinary work is to be done, and impact of pregnancy on long-term allograft function has to be established. I would like to have an expert opinion from Dr. Jodha regarding this case. Dr. Jodha, please. Sir, please, your comments.
All the panelists has given the essential answers requiring these patients who are in, because these patients are not common patients which we are getting in our day-to-day practices. They are coming infrequent. So the patients are to be kept in a good tertiary care centers or the team where the combination of nephrologist, physician, obstetrician, senior obstetricians who can take care of, and the backup of ICU facilities, because they may go worse within hours. So these things are kept in mind, and the questions you have raised for these patients is equally important, and especially keeping prevention aspect at every steps of first trimester, second trimester screens, and taking good care of fetal well-being by regular Doppler assessment, when to have intervention. So it is a nice question and answer sessions for all, and we are also learning from these, because these are the one of the rare events which most of these centers are not having these cases, because these are not reaching to the all private doctors or other institutes.
Moreover, the guidelines are not available. So, you have to follow your own guidelines to take care of such patients.
Yeah.
So to case...
And there are many physiological changes also occur during the pregnancy for the kidney function test. So we should be well aware with these things also, because there's an increase in GFR and all the things.
Yeah.
And overuse of oxytocin also should be kept used judiciously, because it also causes fluid retention and all. No?
Yeah. So that is why, the balloon tamponade was done, so that we don't have to give anything else than the mechanical method to stop the bleeding. And the bleeding was probably because of the raised blood pressure which she was having because of the chronic renal disease. So now
moving to also low in that particular patient. She has kept platelet counts were also 80,000.
Yes, to the lower side. Yeah.
So these things are key.
So moving on to case 2, Primi Gravida, 28-year, delivered at 8 a.m. at a PHC, referred to higher center at 12 noon for excessive bleeding PV. On examination, her GC was fair, slightly confused, pale, pulse 140 per minute, BP 90/60 millimeter of mercury, PA uterine fundus not palpable, and vaginal packing was packed. Vaginal packing was present. Investigations, a quick investigation, hemoglobin 8 grams, TND count 29,800, platelet count 1.2 lakh per minute, BT-CT prothrombin time normal, renal function test normal, and urine of around 100 ml in the urobag. The patient was directly shifted to OT for resuscitation after taking consent. Blood products arranged, fluid started with white bore cannula, anesthetic called, packing removed, a globular bulge felt in the vagina, bleeding PV present, repositioning of the uterus done with difficulty as constriction ring was very tight, medical management given after the repositioning, uterine tone not good, again balloon tamponade done, broad spectrum antibiotic given, and post-operative monitoring done. So this was before the repositioning of the uterine fundus. So now the question is, as Dr. Sadhana has already mentioned, what is the shock index in this patient, and what is the significance of shock index in this patient, Dr. Suchitra?
her shock index is a little bit higher. Shock index must be remain within 0.5 to 0.7 as the heart rate is above 140 and systolic mean blood pressure was little lower side. So mean shock index is very important. If it is more than 0.1 and in this case this is more than 0.6, so she is in a shock and in a moderate shock, so we have to manage it as a massive PPH, and she is having a case of acute inversion of uterus. So accordingly we have to manage with the blood products and 1:1:1 with a 1:1 ratio.
See here, there is the pain may also cause shock in this patient, but here
Yes.
the shock index is going to tell us that there is a loss of blood also in this patient because 4 to 5 hours have passed since the inversion uterus. And because of packing, the bleeding was controlled, but still she must have bled. That's why the shock index is higher. What initial examination? The initial examination was done in OT, not the triage area. Was it justified? Dr. Mamta? Dr. Monica? Was it justified?
Yes, because we have already seen that the fundus is not palpable. So we were having a little bit idea, and the hemoglobin was 8 gram%. It was not a basically a hemorrhagic shock. So we would have thought that it is basically a neurogenic shock because the patient is suffering, and we had an impression that it can be an inversion of the uterus because of both the findings. So better to keep the patient in OT, remove the packing, and do the reposition at the same time.
Dr. Akriti, I would like to ask, how will you manage and what are the techniques, to deal with such cases?
Ma'am, as the patient has been timely taken to the operation theater without wasting much time, the initial step is to initially we discontinue the uterotonics so that the repositioning can be done first. We should call for help. Appropriate staff, anesthetist and extra staff should be available, and all the IV lines should be secured. And after initial things, the first thing is that we should not, immediately the repositioning of the uterus is to be tried. In this case, the Johnson maneuver which is used to place a hand inside the long axis of vagina and push the fundus along the long axis. And in case the constriction ring is very tight, then in that case laparotomy is required, and then the patient would have other methods of like Huntington and Holton's methods are used to reposition the uterus in that cases. After the repositioning has been done, after that if the placenta has not been, in case it is not removed, then the placenta should be removed in cases where after repositioning, and then the uterotonics should be started. Good antibiotic cover should be given to such patients because of so much of handling has been done. The patient has been referred and again repositioning has been tried vaginally. So a good antibiotic cover should be given to such patients.
Anything about the hydrostatic method of repositioning?
Ma'am, in case the vaginal repositioning, the Johnson method fails, and then the laparotomy of Huntington and Holton's method are tried and not done. Some people try hydrostatic where the pressure of water is used. Ma'am, I have not had any experience of.
Yes, we don't do it. It is mentioned. Generally, we are able to reposit it back, and we are not. We don't have to resort to, the laparotomy part also because the patient is already low, right? So, and now I would like to ask Dr. Shubhra, was balloon tamponade justified, and what sort of antibiotic coverage are we going to give to this patient?
Ma'am, actually our prime motive should be till the time the patient is being shifted to the operation theater. If the inverted part is coming out of the vagina, means inversion is more, then we should cover the means exposed part with some sterile drape or with some betadine or some covered gauze, and so that which reduces the infection also and the edema as well. And if it's exposed outside and it's long been handled, then we can give triple antibiotic like amoxiclav or gentamicin and metrogyl. Otherwise, I think amoxiclav is sufficient if it's an acute inversion.
Okay. What long-term follow-up are required, Dr. Savita, in these particular patients? Dr. Savita? Dr. Shubhra, can you take this question? What long-term
Yes,
follow-up is needed for these patients?
ma'am, sometimes the inversion can recur. So we should keep a clear follow-up on them.
That's why the balloon tamponade was done, to avoid
Yes,
the
ma'am.
recurrence.
Yeah.
Right?
And
That's why
we
it
can
was
also
done.
we can also place that SR cannula also nowadays.
Yes,
ma'am.
that also can be done. Right. Anyway, anyone wants to speak? Dr. Shuchitra, you wanted to speak something?
In long-term cases, we have to take care about the infection prevention also. So
Yes. In this
We have to
particular
look for
patient,
the secondary PPH also.
yes. In this particular patient, the packing was not removed at all in the triage area. She was directly taken to the OT, and only after the resuscitation measures were done, then the packing was removed. So shock index is important, as Dr. Monica has already mentioned. In this particular patient, it is particularly important, and we have to take care proper labor management by trained staff. Importance of training of the staff, like Manyata training for the staff, is very important, and that also should be done regularly. AMTSL, of course, is important. Inversion uterus should be corrected as soon as diagnosed. Shock index helps us. Reference protocol, how you are going to refer, that is also important. So reference protocol should be followed. Shock and uterine reposition should be done simultaneously. You should treat the shock as well as deposit the uterus simultaneously. So,
Dr. Jodha's comment, and Dolly, I will like to say the experience that really we are getting inversion, because we think that it is very rare, but some like teaching institution people say that they happen. So Dr. Jodha's comment that how.
Thank you,
your
ma'am.
comments?
Because these are the things which we often getting in our emergency cases, receiving these, or the higher load obstetric units are also having inversion of its own in the hospitals also, when newer batches of postgraduates are coming and they are giving extra sort of cord tractions and creating such problems. So these are the situations we are facing, and if these are available, the things usually we do the reposition at the same time. It is acutely inverted, and most of the times they are successful. But if they are a little bit delayed, the shock content is also the out of proportion, because the amount of losses may not be there, but the patient is seen as a drained out and it is in deep shock. It is pale and like gasping patient, and at the time you reposit it, within a minute you will see that the patient is recovering well. So this is how this makes it's a combination of blood loss, hemorrhagic, and more neurogenic shock, which is causing pressure on the nervous system of that. And we had the experience of putting this saline and putting back. This O'Sullivan's method has been tried, and we are having opportunity to have successful repositing the inverted uterus many times. So it is also functioning good, because the situations which we are having in the patient in the OT table, and the patient is well in anesthetic agents. So the relaxation part is very good, using good amount of halothane or isoflurane, which makes the uterus very lax, and you can overcome the constriction part. And mostly these patients, after repositions, we are keeping our hand at least for uterine contractions, which has make it hard till oxytocin has worked. So it is keeping either for that particular 2 to 5 minutes, or putting these tamponades is also helpful. So it's a good experience of seeing these patients in tertiary centers, and we are getting these patients on and off at least 4 and 5 per year in tertiary centers.
Thank you, sir. As already mentioned by Dr. Sadhana Gupta, in such patients, we have to draw 20 ml of blood, and these vials, which Madam had also mentioned, they should be ready along with the PPH tray to deal with such patients. And In such cases, the documentation is very important. Staff in attendance and the time they have arrived should be documented. The sequence of events, the administration of different pharmacological agents, their timing and sequence, the time of surgical intervention, the condition of the mother throughout different steps, the timing of blood and the fluid should also be mentioned in our documents. I would now like to call upon Dr. Aditi for the case 3. Dr. Aditi? Dr. Aditi, are you there?
Shall I share some of the information regarding
Yes, sir.
cannula?
Yes, sir. We would like to listen to your experience.
Thank you. Thing no, there is a difference between balloon tamponade and suction tamponade by SR cannula, because balloon cannot hold itself to the cervix. When the uterus start acting, the balloon comes out. So you have to pack the vagina to see that the balloon should stay inside. But suction SR cannula is not like that. Because the tissues, cervical tissues get stuck into the holes of the cannula won't come out. It will stay there. And it perfectly creates a negative pressure inside the uterine cavity, which stops bleeding. That's the advantage. Other thing, in case of uterine inversion, as we have discussed now here, the moment uterus comes out, you always keep one suction cannula in every delivery tray. That's what my suggestion. If it is a PPH, if it is an inversion of uterus, whatever it is, the moment you see excess blood, don't wait till the blood loss more than 300, 400 ml, and don't try all other ml. First thing, what my advice, no, insert cannula. The moment you see excess blood loss threatening severe PPH or PPH, insert the cannula and apply negative pressure. That's the end of the story. And you will not see PPH at all. That's what I am suggesting. And all of you know, we should definitely make one 2-3 sessions. Actually, in Tamil Nadu, what we did, no, it is not possible for me to cover entire Tamil Nadu in one stretch. And government of Tamil Nadu, what they did was, they selected 3 centers, Chennai, Madurai, and Salem. 23 medical colleges in each center, 23, 22, 23, around 60 or 69 medical colleges. We have trained trainers. These trained trainers went to their mother hospitals, and further they trained their subordinates and the institutions below them. So now within no time, within a month time, SR cannula reached every part of Tamil Nadu, and they are using now. Currently, the staff nurses from primary health centers, they've been getting training in this SR cannula application in medical colleges. Because in primary health centers, even though doctors, male doctors, female doctors are there, the persons who conduct deliveries are staff nurses, because now staff nurses are getting trained. So this is what I would like to share with you. And if you can facilitate some training programs, I will be very happy to come and do something there. I'm really interested to do that.
Thank you so much, sir, for the insights. Thank you for your valuable opinion, sir.
Thank you. Thank you very much.
Dr. Aditi, are you there to take up the case 3? Dr. Aditi?
Yes, ma'am. Am I audible?
Yes, yes. Go ahead.
Yes,
please.
actually, I have an unstable connection, so I'm using the mobile. Good evening,
no
everyone. And thank you. Good evening, everyone. It is a very nice session. And thank you, ma'am, for making me co-moderator with you. So without wasting time, we'll go with case 3. A Gravida 5, Para 4, 30-year-old average build female was referred from a PHC at the case of non-progressive labor. She was in labor for the last 10 hours. There was history of taking misoprostol 200 microgram given orally by the ANM at PHC 4 hours back. On examination, her general condition was fair. The pulse was 110 per minute. BP was 110/70. For abdominal examination, the uterus was term size, head was fixed, and uterus was hard. FHS was regular. On PV examination, the cervix was 6 centimeters dilated, fully effaced. Vertex was at -1 station, and the bag of membrane was there. Pelvis was adequate. On investigating her, the blood group was B positive, hemoglobin was 10 gram, BT, CT were normal limits, platelet count was 1.3 lakhs. PT-INR could not be done. She delivered normally immediately after reaching the hospital. Active management of 3rd stage of labor was done. Placenta was delivered completely with membranes and checked. There were no cervical, vaginal, or perineal tear. Uterus was well contracted.
So 2 hours after the delivery, Aditi, go ahead.
Around 300 grams of cloth was from vagina. Pulse 120 per minute by 60. Hello?
Yeah, go ahead, Aditi.
The uterus was contracted.
Some connection problems is there.
Yes, sir.
Yeah. Patient was shifted to labor room after taking consent. Crystalloid was started and 2 whiteboard cannula were inserted. Anesthesiologist was called, blood products arranged, injection tranexamic acid 1 gram given, diluted over 10 minutes. Post-delivery vaginal examination was done. Now the questions are, this is a very atypical case, as Mama said, we have to decide, should labor be augmented and how? And what should be the criteria?
Dr. Shuchitra?
Yeah, in this case, the labor was it was augmented, but it was not taken care as the patient was not 200 microgram misoprostol, which was given to the patient. That was not a criteria of augmentation, and for the augmentation, she was not in labor at that time. So this was not a right decision. And prior to induction or augmentation, we have to decide the indication of augmentation. So
The next question is how and how long should a delivered patient be monitored? Dr. Monica? How and how long?
The patient should be monitored till the patient passes the urine. That is the 4th stage of the labor. At least for the 1 hour, there should be a monitoring into the postnatal ward. Or even in the labor room, we can have a special ward before shifting the patient to the prenatal wards, postnatal wards. So if the patient passes the urine, most of the problem have been solved. But many times what happens, slowly the patient, the uterus is contracted at that time, and it gradually goes into the atonicity, and the PPH, atonic PPH occur. So we have to be very careful, and we should monitor them properly. If we have got some sign for the tachycardia, the staff should be very vigilant. Even the buy of the labor room, they always say कि madam थोड़ी bleeding ज़्यादा हो रही. Even they are more trained than I think for the nursing staff. What we feel like कि they tell you कि madam patient की bleeding ज़्यादा हो रही है, you just see the patient and there's an atonic PPH. You do the management of the atonic PPH and the patient is improved.
Yes. So Dr. Akriti,
should blood products?
Go ahead, Anti.
Yeah. Should Dr. Akriti, should blood products be arranged for all laboring patients?
Dr. Akriti, are you there? Dr. Akriti, Dr. Shubhra, you can take up this question.
Ma'am, blood products ideally should be arranged for all. At least for high risk cases, we should arrange, and for other, we should get the blood cross match done.
Okay. How do you quantify the blood loss in this patient?
Ma'am, we can have calibrated drapes we can use, or we can put a calibrated jug to quantify, or we can also weigh the mops or the drapes which are used pre-delivery and after delivery, and we can subtract. Before that, we should take care that amniotic fluid should not be counted in those drapes.
in a delivery kit, we also have drapes that are we putting the beneath the patient and that have the marking.
Yes.
Calibrated markings, yes, ma'am.
So we have 3 methods. Could you stress on the methods of quantifying blood loss?
What are the 3 methods of quantifying the blood loss? The visual estimation, the volumetric estimation, and the gravimetric estimation, right? So we should also train ourselves, and we should train our staff, as you mentioned. We should train our staff to see and judge how much is the blood loss.
So what would you have done to control the bleeding in this patient? Dr. Taru?
Dr. Taru is not there. Dr. Shubhra, you take up this question. What are the various methods? Whether you could have done the transvaginal uterine artery clamp, the SR PPH cannula, packing, what?
Ma'am, first of all, we'll try for the medical management.
That was given.
After that, ma'am, we can do uterine massage and uterine compression. And if it fails, then we can start shifting patient to the operation theater.
She's in the labor room. She's in the labor room. I'm talking about these two methods. This can be done in the labor room as well. We don't have to shift her to the OT.
Yeah, ma'am, we can go for tamponade, or we can go for SR suction cannula.
So
I haven't used this uterine artery clamps yet. Yeah, ma'am.
Okay.
First, we can look for the tears. There can be tears inside the uterus.
That was
Cervical
checked.
tear or the
That was checked. That was done.
should be ruled out. Yes, ma'am.
it was already checked. So there was oozing from the lower segment. So what would you have preferred doing in this case? The combination of both would have worked well. Suction cannula as well as the transvaginal uterine artery clamp. So
we can do packing also.
And
Now we
packing
can
also.
with a hemostatic injection, there's a one now the better hemostatic agents have come, and we just pack this thing and we can see the oozing is stopped by that. Even the surgeons are using in the hepatic oozing also. So we can, I have tried in many patients and I got a good results out of that.
But these two methods are good. You know, there is a transvaginal uterine artery clamp by Dr. Piley. We can just clamp the uterine artery vaginally, and as well as at the same time, you can insert this PPH suction cannula, which sir had already shown, and the bleeding will be under control. And you can just follow up this patient. You need not pack, because packing, you know, it's not a very foolproof method, but these are proven foolproof method to control bleeding in such patients. What about role of carbetocin? What about role of carbetocin, Dr. Suchitra? We have already used oxytocin. Will you give carbetocin in this patient?
In this patient, as she's not having any atonic PPH, so if she develops after the bleeding, if it develops atonic, then we can give the carbetocin. Otherwise, we managed it medically. So these are the better methods to put a PPH cannula and a transvaginal uterine artery.
But since we have given oxytocin, ma'am, the carbetocin will also work on the same receptors, so the efficacy would be less, ma'am.
Moreover, the US FDA approved only the prophylactic use of the carbetocin. They don't prove.
This is what we wanted you to speak.
Allowed to use it after the PPH occurs. So if we document, we will be in the trouble. So we should use only those drugs who are approved by some of the guidelines.
Right.
So what will be the role of bimanual compression and aortic compression?
Dr. Suchitra, role of bimanual compression and aortic compression in this patient?
As we have already applied uterine artery clamps, ma'am, so
but this can be done, you know, while you are shifting the patient to the labor room.
Yes. Yes.
Right?
Exactly. Yeah.
Dr. Shubhra, what about the blood transfusion protocol?
Ma'am, if the patient, we should arrange and cross-match blood, and along with that, we should also arrange for FFPs and platelets. And if she needs more than 4 units of PRBCs, then we should also use massive transfusion protocol and transfuse FFPs and platelets also along with that.
Right. So I would like to hear suction, SR suction PPH cannula was inserted. For 30 minutes, the suction was there. The suction was, the cannula was left inside for 24 hours. And after 24 hours, the cannula was removed. The patient was comfortable. Dr. Jodha, I want your comments, your expert comments on this patient. Jodha sir, I want your comments on this patient.
The things has been done for these patients who are multigravida, not to be promoted to give these types of medications at these centers, because she is fortunate to not to have rupture of uterus, because she has reached to the hospital with fetal heart rate and not in shock or not in rupture. So it is very good to say these peripheral staffs who are taking care not to venture for augmentation or stimulation, or like using misoprostol as a drug for that particular type of augmentation of labor. That is to be given. Otherwise, the things which we are doing for these patients is a very nice. The things, the clamps which Dr. Piley has invented, though we have not used that, but sometimes you can put a big alleys for over that particular, pulling their cervix and putting sponge holding forceps at that particular area of that. That can be also tried if there is this is not working, then you can try it also, and this is also helpful in controlling some of these till you do other types of preparations for laparotomy or surgical intervention in these group of patients.
Shall I share some information, sir?
Yes, sir.
So, as I told you in my presentation, we advise in peripheral centers with suboptimal facilities, I advise them to apply SR cannula for every delivery because they don't have facilities for blood transfusion and many other things, transport and all. Because of that, no, the referrals to the referral hospital has come down. The risk of acceptance, no, previously with anemia also they used to refer the case because they are afraid of PPH. Now, certain cases, they have PPH occurred in peripheral center. They have applied, bleeding stopped, small trickle of blood was going on. They referred the case to the SVMC Medical College with cannula in situ. And the woman reached there with cannula in situ and bleeding was not much. They want to give a trial of waiting for another few hours. They waited for 24 hours. After 24 hours also, there was a small trickle of blood from vagina. They take a decision to open the abdomen. When they opened the abdomen, there was a big broad ligament hematoma with rupture uterus. So what I would like to say here, cannula is, if at all cannula would not have been inserted in peripheral center, definitely the woman might have lost in the transit. So what I would like to suggest, no, if you can insert the cannula properly, that is inside the uterus, not into the peritoneal cavity, even with partial rupture of uterus, bleeding, we can buy time. And we can buy time and save the life. The similar case has been reported from Rajasthan, Udaipur. We have published in this Facebook group, Bobigan Facebook group. This is one thing. The difference between cannula and transvaginal clamp, no, I would like to say Paili sir is my teacher also. I got highest respect for him. Certain differences are there. Application of SR cannula and application of transvaginal clamp, there's a lot of difference. Application of cannula is more simple when compared to the clamps. Other thing, the anatomy of uterine arteries is not same in every patient. It may vary. Sometimes you may be able to catch the vessel, sometimes you may not be able to catch the vessel. It's almost like a blind procedure. Third thing, we cannot address the blood supply from the ovarian vessels. Ovarian vessels are high up. Sometimes major blood supply comes from ovarian arteries. In such cases, cannula, this clamp may not be successful. So my first option, better we insert the cannula because bleeding almost very rare cannula failing. This is what my opinion.
I will like to say, Dr. Samartha, what we said in the last webinars, that you please provide love to the dolly. You take follow of the patient, Dr. Samartha, that he will provide at least 5 sets of SR cannula to our expert dolly. Dr.
I already have one, ma'am.
You already have. So it is your, Dr. Samartha, it is your commitment that first you make available few sets and of course it will be propagated like this because it is a lowest thing, like lowest resource setting can use it and it is a very, very quick procedure. So one has to believe to see to believe it. So
no, I got it 5 years back from AICOG, started using it. All the juniors in Ratlam and all my seniors in Ratlam, after seeing me use, they are using. So in Ratlam, all of us have the SR PPH cannula.
Oh, thank you very much.
And we got it from AICOG.
I would like to ask you one thing. You have been using this. Any failures are there?
No failure at all till now.
That's what I'm telling. That's what I'm telling. No failure. It is not only from not only from Dolly Mehra. It is from everybody, entire Tamil Nadu, Kerala, Andhra Pradesh. So my suggestion, no, you need not. It is not very expensive. It is very cheap, and we are giving the entire 5 cannula set for 11,200 rupees only. See, you see, one patient bleeding costs lakhs of rupees sometimes, and we should stop bleeding immediately. It avoids so many complications. I don't mind sparing some sets for my friends here, but you give their names.
Okay, sir. Thank you.
Thank you.
Thank you for the insight. So the
We are
points to
also
ponder.
using transportation. We are also using Nasji garments, and we have provided to the peripheral centers these Nasji garments while they are having the problem of transporting these type of patients who are having shock and PPH. So they are also helpful.
But appearance of NSG garment is late part of this thing, sir. But cannula, you can once you cannula is
definitely.
Once cannula is used, no, many things become irrelevant. That's what I would like to
Sir,
say.
NSG is very useful while transporting such patients. That, of course, is it has its own place in transporting these patients, and cannula is important for the controlling of bleeding. So
Sure.
both the things are important. You know, when you are transporting the patient from a PHC, it is important that you put in an NSGH garment and then transport the patient.
Simultaneously, if cannula is used, then it is it's a better placed patients or a referred patient.
I would like to share one more information here. We induced this. We started this cannula application in SVMC Tirupati. Every day 50 deliveries are there. For last 4 batches of postgraduates, they have not seen B-Lynch procedure. So I have given 15 cannulas free to them and 3-4 sets free to them. Now every postgraduate applies it. So the reason is, for the same reason, the blood transfusions has dropped very significantly and laparotomies have disappeared. So one thing I would like to say, we must take this to a very grassroots level, and especially my concern is we could do something very significantly in South India. All South Indian states, we have already achieved less than 70 mmR, which is a target for us. But North India around still 150, 160 mmR is there. All of us, Foxy, once our Sadhana ji becomes president, no, she should take only this challenge. If she take this challenge, that is enough for the life. That's what my suggestion. We should seriously consider.
Dr. Samartha, it is my one of the most priority vision that is a preventable mortality from PPH and adoption of maternal care bundles pan India by obstetrician and gynecologists to reduce the maternal mortality as well as the criticality. So this is my vision, which I have shared, and it is available on like Facebook and everything. And we need to have the association like wonderful people, Dr. Pelly, you, Dr. Jodha, Dr. Dolly. We've seen a leaders, and what everybody have got the leader when we go. And Dolly is saying this example. And I've been to Siwan, Muzaffarpur, and there are so many experiences, including SR cannula, and we can do a lot together. And one very important thing, why Dr. Samartha is actually emphasizing it, because as an Indian, we have something issue that we are not confident on our own innovation. So Bakri balloon, it is 20,000 rupees, and so many things which are very, very costly. And it is like the aim of keeping all these sessions and including learning from everybody, that we believe on ourselves and what works for us. That is the most important thing. And Dr. Samartha, like this is one of my priority. And
thank you. Thank you very much. Thank you very much. You have already made SR cannula pan India now through these webinars, and we should really take this SR cannula to every delivery room in North India. That's what I ambition.
So to move ahead with the panel, the points to ponder from this patient is, we should avoid augmentation of labor if it is not needed. Blood products to be arranged for high-risk laboring patients. AMTSL is mandatory. 4th stage of labor should be managed properly. Any blood loss causing hemodynamic instability should be detected and treated urgently. Facility preparedness should be there. Novel, newer methods are useful. Prompt complementary action is needed, and anticipation, early detection, appropriate management is very important. So this is the visual estimation, and these are the FIGO recommendations, which we have already mentioned. Because of the lack of time, I'm moving quickly. This is very important, the bundle approach, which Madam Sadhana had also spoken of, the first response bundle and the refractory PPH bundle, wherein the NASG, UBT balloon and compression maneuvers are very important. Dr. Aditi, can you go ahead with this fourth, please?
Yes, we come to the fourth case. This is the case of a primary gravida. She had amenorrhea 8 months. She was a known case of hypertensive disease of pregnancy, but not taking medication properly. Early in the morning, she reported with severe pain in abdomen and syncopal attacks. Then she reported to the hospital. So on examination, her pulse was 120 per minute. Blood pressure was 90/60. She was pale. SpO2 was maintained at 98%. On per abdominal examination, uterus was 24 weeks, tense, tender, and FHS was not audible. On PV, os was closed, not taken up, no bleeding. Urgent bedside sonography showed a large retroplacental clot with IUFT. Investigation showed HB of 7 gram%, TLC 10,000, platelet was 75,000, LFTs were normal, urine albumin +2, BTs, CT were in normal range, PT was 1.8 times the normal range. There was call, the whole team was mobilized. There was a call for help. Blood products were arranged, consent taken, anesthesiologist called, and the patient was shifted to OT for LSCS. A dead female child was delivered. Liker was bloodstained, placenta was out, retroplacental clot measuring 800 ml expelled, carbetocin given IM, uterus contracted, covalent, lower segment closed but bleeding PV present, injection tranexamic acid given but bleeding continued. The on OT table, bilateral uterine artery ligation and ovarian artery ligation was done. FFP 2 units were given, followed by Pexcel. Uterus was checked, contracted, bleeding per vaginal control after 30 minutes of waiting. Hemostasis checked, abdomen closed, shifted to ICU for monitoring, bleeding PV control, uterus contracted. This was the retroplacental clot. Now we come to the blood supply of the uterus. Here already ma'am has taken up. Now the questions are, how do you do uterine artery ligation? That ma'am has already taken up the thing. The questions are, was LSCS justified?
Dr. Suchitra, can you take up this? Are you there?
Yes, yes, cesarean was justified in this case as it is a clear-cut case of abruptio placentae with the IUFT. So the page, according to the page grading, she must be a case of stage 3 and with the vitals compromised. So it was a good decision for the cesarean section in this case. And
what kind of fluid should be given? Crystalloids or colloids?
Crystalloid is the preferable choice is crystalloid. And if we till the time we arrange the blood and the blood products, that till that time we have to give the crystalloids and then followed by the blood transfusion.
So what I would like to ask, what should be the rate of administration and what should be the monitoring when you are doing the fluid resuscitation? Fluid resuscitation is also very important in these particular cases. I would like Dr. Shubhra to answer this question. What should be the rate of administration of fluid in this patient and how you are going to monitor? And when are you going to give the blood products? Dr. Shubhra, are you there? Dr. Akriti, you take this question.
Ma'am, am I audible?
Yeah. Dr. Shubhra, go ahead.
Yeah, ma'am. Ma'am, crystalloids should be preferred as compared to colloids. And crystalloids, the total quantity of crystalloids to be transfused should be approximately 2.5 to 3 times of the estimated blood loss. Like if she's having 500, then we can give up to 1500 ml. And colloid should only be given
if the blood products are not available.
If we have given crystalloids up to 2 liters, and then also if we are seeing the deterioration in the vitals until the time blood products are being arranged. And for blood products, there's a massive transfusion protocol is there, though there are no national guidelines for that, but still there are some criteria which we can see, like if her temperature is less than 34 degree, her pH is, Blaise deficit is more than 6, or her pH is less than 7, her systolic blood pressure is less than 90, and her blood pulse rate is also higher.
How will you avoid trolley in this patient?
Ma'am, we should have a watch on lung auscultation. We should not allow the fluids to get overloaded, and so lung injury can be avoided. And
No.
patient, yes, ma'am. We can give Lasix also if more of the blood products are being transfused.
Fine. So in this patient, we were anticipating DIC, and hence, the plasma was transfused earlier, and that's why the uterine bilateral uterine artery ligation and the utero-ovarian anastomosis were ligated. We've already seen in the videos how it was done. We waited till the bleeding stopped. Otherwise, the internal iliac artery should have also been ligated in this particular patient. So these are the various methods how you should do the resuscitation. That is also very important in these particular patients. And you should have an aggressive management should not be done. A hypotensive resuscitation should be done. Aggressive resuscitation may worsen coagulopathy, particularly in these sort of patients. Dr. Jodha, I would like to have your opinion about the resuscitation, fluid resuscitation, what precautions we should take.
Most of these patients who are having shock in conditions, and we try to overcome that particular situation by pushing large amount of fluids, the risk of pulmonary edema or may be very much high. So keeping these things in balance, that fluid along with the blood and blood products are to be given in such a way that we are just able to maintain the good pulse pressure and BP of that particular patient, and oxygenations and the pH level up, and the use of blood products in combination of RBCs and platelets and plasma in a ratio of 2:1 or 1:1, like that will help in that particular patients to avoid these type of situations, because these patients are worsened by mismanagement rather than by providing these type of enormous use of large amount of blood and blood products, especially massive transfusion protocols. The patients may go in the trolley and various organ dysfunctions later on.
Thank you, sir. So the therapeutic goal should be, Dr. Aditi.
The therapeutic goal should be HB greater than 8 gram%. Platelet should be maintained more than 50,000. PT and APTT should be more than 1.5, and fibrinogen levels should be more than 2 gram%. And as this is the PPH emergency care checklist. So in the first response, we give IV fluids, uterotonics, tranexamic acid, and uterine massage. Every labor room should have this. The time it has been started and finished, and what was done and what was not done should be charted. Whether tears were checked for, and compression, and if it is a refractory bleeding, then compression has to be done. Either of the two, either aortic compression has to be done or bimanual compression has to be done. Next.
So this is regarding the uterine artery ligation, which we have already dealt with. So I'm not going into the details. We are not taking up the fifth case, but the important thing is what take-home messages. I would like to have one take-home message from all the panelists. First of all, I would like to have Dr. Jodha's opinion. What take-home message are you going to give to the delegates?
The patient whom you address as a case of PPH in your emergency or receiving, you should be alerted your colleagues that these are the patient who is reaching to us, and we should be having a team of, because that is the particular time where initial 1 or 2 hours will be helpful for preventing the complications, morbidities and mortalities in these patients. Initial handling by a junior registrar, then senior registrar, then calling the senior most, and wasting that particular time where intervention can be helpful for preventing these patients morbidity and later on the organ dysfunctions, and shifting these patients to the various ICUs. So immediate attention to attend these patients and collaborate all the team members to reach and advocate the proper PPH drill among and addressing these issues as early as possible to prevent the complications which are going to happen in these patients most of the time, and which may be preventable if you address these issues at time. So this is to be kept in mind, because we have many options to do with these patients, but at least we should be doing it uniformly with the same motive and with the team effort to prevent these complications.
Thank you, sir. Your opinion, Dr. Monica?
We should we should know that PPH can occur in any patient. Though it is more in the high-risk patient, but most of the PPH occur in the normal patient also. So all the time we should be very alert with the patient. We should do proper counseling, and antenatally we should take care of everything. We should never take anything lightly. Carry if the primary या second gravida hai, she will deliver normally and nothing will happen. It's not like that. When we should be all the time alert, and we should give our staff a PPH drill. There should be a PPH drill always ready in the labor room with all the facility, and mock drills of the staff is done because we are there. We know each and everything, but what is the importance is the teamwork. The staff and everybody should be helped. When you call for the help, the other people are able to help you out. They should know what is the importance, because the PPH is the most important cause for the female death and for the litigations what we face. So we all the time the proper documentation, counseling, training, mock drills, everything is important, and we should be every time alert and should ready to manage the PPH.
Dr. Akriti, your point for PPH? Your take-home message, Dr. Akriti, are you there?
She's not there, ma'am.
Okay, Dr. Shubhra?
Yes, ma'am. Ma'am, I think that while PPH occurs, instead of telling only the commands that you need to bring the blood forms or you need to do, we should designate the person also along with that, that Sita, you go there, and Reena, you do this, because the hassle happens that all of them start rushing towards bringing catheters, or all of them start rushing towards filling the blood form. So the work should be designated either prior or at the time the consultant should be telling along with the names, so that the time is not wasted and there's no hassle in that.
Dr. Suchitra, your opinion?
After attending this beautiful and a worthy webinar, and as we are doing everything for the PPH management, and but I want to use this SR PPH cannula in my labor room very promptly, so that we can avoid the nephrotomies and like more morbidities and mortality. We can prevent by this, as we all are doing the PPH management beautifully and everyone doing best at their part, but still we are not using this SR PPH cannula. So I would like to
we should all start using it.
Yeah, I appreciate
this. Thank you so much. Dr. Aditi, your final comments? Dr. Aditi, your take-home messages?
Yes, ma'am. My take message is this: as ma'am said, you should anticipate PPH in each and every case. Every patient in labor is a potential PPH case. The team should always be ready. The facility should be ready, and the work should be designated. There should be PPH drills always, so the staff should be trained, and there should be a proper protocol. It should be written on the labor room what has to be done, how it has to be done, and you should always have a cool mind, as ma'am said, in internal artery ligation. You should always have a cool mind. You should not shout and scream. You should go. It is easier said than done always. And you should time. The decisions should be very timely. The decision should be timely. You should not wait for the patient to deteriorate and go into DIC and then do something. The decision has to be very timely and done in time.
Thank you so much.
And as
I am really grateful to our expert, Dr. Jodha, and to all our panelists, Dr. Monica, Dr. Suchitra, Dr. Shubhra, Dr. Akriti, Dr. Monica. And I'm really grateful to Dr. Aditi, my co-moderator, for helping me in this. I'm grateful to Dr. Sadhana Gupta ma'am and Dr. Babita for giving me this opportunity. Dr. Sadhana ma'am, your final comments.
Wonderful case compilation, Dolly, and we are very, very happy to have you and all the wise inputs from all the panel. And always, when we listen to all panel, we always learn from their experience that what is happening. Like Dr. Jodha rightly says, that 2 or 3 things that wasting time from one person see, then other person see, and we are having the situation like inversion, which is fairly preventable if we really follow the good labor room protocols. So it is always like this is the thing which we are accumulating and we are collecting from all the expert and what is happening from the teaching institution at the small 1 or 2% hospital, like Monica rightly emphasized that we have to train, like we know, but our nurses don't know. And sometimes the experience overall, like what we say, Monica, I think she was saying that sometimes the like a new nurse can be less experienced in detecting PPH or the criticality than our old person. So there are few very, very important point, and of course we have to believe SR cannula, transvaginal uterine artery, that is a simple instrument also, transvaginal uterine artery clamp, and it can be very, very good option when we are like struggling with the high cervical tear and we are not able to getting a good repair. It gives us time and it sometimes correct us. So we have to believe on ourselves and we have to create the system. So it was great panel discussion, and always that experience is very, very important and very, very precious for us, so that we can plan ahead that what we can do together. Actually, it is not just like something about knowledge. We have to turn knowledge into action, and that can only happen when all of our mind and hearts are working together. So this is the way, and it is great. And I again have a gratitude for all the society office bearers for being with us, all our faculties and our panel moderator Dolly, Aditi, because we have हमको अपना कारवां बढ़ाते जाना है, और अच्छे लोगों के संग में, जो लोगों को हृदय दिल में ये मिशन है कि हम अपने लोगों के लिए, अपने फेलो ओबी गायनी के लिए, अपने कंट्री के लिए, अपनी स्टेट के लिए कुछ करें, और ऐसे ही लोगों के कारवां से हम लोग किसी मंजिल पर पहुंचेंगे. So thank you very much once again from my part.
Thank you very much.
And Dr. Ved, yes. So,
so ma'am, shall I give the official vote of thanks now?
Yes, you give.
So, as sincerest
Leela ji is with us. Leela ji is with us, and Dr. Veena Acharya is also might be listening. So, thank you, Leela ji, for this.
पिछले 2-3 दिन से बाहर थे, तो इसलिए पेशेंट्स देखने थे, बट आई एम गेसिंग बहुत
पेशेंट
अच्छा.
तो हमारे भी पीछे पड़े हुए होंगे, अब भागेंगे अब जाके. मैंने कहा पेशेंट तो वहाँ हमारे भी पड़े हुए हैं, अभी भागेंगे अब यहाँ से.
आप तो भागोगे अभी. आज मैं प्रिविलेज थी ना कि मेरे को हमने कहा ठीक है, बात कर लो का.
ठीक है मैडम. Thank you very much, and best wishes Dr. Sadhna ji. Thank you very much for future endeavor.
Remember to vote for me full-heartedly.
Ma'am, vote and support.
Yes. Dr. Veena, madam, thank you for staying till the end. And Babita, you must
it is
be
really very informative. I must congratulate Dr. Sadhna. It is really wonderful, and it is the really need of ours. We have to join two hands together to save the life of humans. Thank you so much.
Thank you. So Babita, you can say official vote of thanks.
Sincere thanks to the societies of Jaipur, Alwar, Ajmer, Udaipur, Bikaner, Hanumangarh, and Ganganagar. My thanks to most respected Dr. Veena Acharya ma'am for her words of wisdom. We are really thankful ma'am stayed till the very end, and she we had the privilege to listen to the webinar with ma'am. Madam also did, and we are very thank you so much ma'am for your input. Madam, she has been working really hard these past few years to spread knowledge in all the societies of FOXI. We wish her very best for a FOXI presidential candidature. Then our thanks to speaker Dr. Samarth Ram and Dr. Shashi Kavra ma'am. They are always, their videos are always like very, very interesting, and I've been watching them in all the webinars, and I still watch them with same interest. Our sincerest thanks to Chairperson Dr. Sunita Agarwal, Dr. Prakash Jain, Dr. Devyani Ranawat, Dr. Charu Chori, Dr. Purnima, Dr. Prema Rathod and Dr. Nikita Tareja for conducting all the sessions so very smoothly. Thank you so much, ma'am. Of course, we had such a wonderful panel today. All the cases were really out of the box, and we had great discussion with wonderful inputs from the panelists. My sincerest thanks to our moderator, Dr. Dolly Mehra and Dr. Aditi Rathod, for preparing such lovely cases and giving such interesting inputs. And of course, our thanks for expert panelist, Dr. B.S. Judha, who kept his patients waiting to give his wise input in our webinar. And to all our panelists, they were really good today, well prepared for all the cases. Dr. Suchitra, Dr. Monica, Dr. Taru, Dr. Subra, and Dr. Sarita. I should not forget to thank my co-convener, Dr. Ayushi, and to the IT team, Kahiti and Tulika, without whose support this webinar would not have been possible. So thank you once again, all of you. And of course, our best wishes to Sadhana.
Thank you so
And
much.
thank you, Babita. Thank you. Thank you for all the great effort.
Best wishes, Dr. Sadhana.
Thank you.
Best
Pakistan is a lovely society, ma'am. I have